Hi,
Hi,
Dr.
Pramila. Good morning.
Good morning. How are you?
I'm good. I'm good. Let me wear my earphones once. So, Sunday morning starts very early, huh?
Yeah. 1 hour of sleep is gone. That's it.
Yes. So, how's college doing? Students are back or no?
No,
I
ours
mean, a
is
hospital.
DM. Ours is DM, so DM was continuing. There was like students all
Yeah.
there, but
Hmm.
MBBS students are back now. Now we are having in-person classes on.
Okay. Pramila, we'll start sharp at 8:40.
For sure, yeah.
Yeah. Okay.
Okay, shall we begin, Pramila?
Yeah, we can.
Yeah. A very good morning to everyone logged in here on this third day of Idec. And to start today's sessions, we have with us a very good endocrinologist and a good friend of mine, Dr. Pramila Kalra. And she is going to be talking to us today about glycemic variability and the evolving role of vildagliptin. Dr. Pramila Kalra is an endocrinologist. She is Bangalore-based and currently works as Associate Professor in the Department of Endocrinology and Metabolism at the MS Ramaiah Medical College and a consultant at the MS Ramaiah Memorial Hospital. She's passionate about teaching and counts thyroid disorders and PCOS as her main research interest. She has received many awards and has been honored many times, and we are very proud and happy to have Dr. Pramila Kalra with us. Over to you, Pramila.
Good morning, everyone. And it's an early Sunday morning, we should say. And I thank Dr. Neeta for inviting me for this talk. And I will just share my slides. It's showing, yeah. Yeah, it's showing sharing, yeah. Sorry. So the topic which has been given to me is like glycemic variability and the evolving role of vildagliptin. Now we know that nowadays, once apart from the HbA1c or the fasting plasma glucose or the postprandial, we also talk about other metrics of glycemic control. And one of the major things which we are discussing nowadays is glycemic variability. So I'll be discussing this in the next 20 minutes or so about glycemic variability and a little bit about the role of vildagliptin in the control of glycemic variability. Now we know that HbA1c is one of the most widely used parameter which is used for glycemic monitoring. But we know that if suppose a patient has uncontrolled hyperglycemia, or suppose today the patient has come and the patient has been started on steroids for some or the other reason, the common scenario nowadays is obviously COVID, but there may be many reasons for which the patient might have been started on steroids, or many things like infection is there or any other reason which is causing glycemic excursions. We cannot clearly see that in the HbA1c because it gives us an average about for 3 months or so. So immediate thing, we cannot just judge from that. Sometimes also we have to see that sometimes what happens, the patient may have some hypoglycemias and some hyperglycemias, but the overall average may look good. So patient may come with a HbA1c of 7, but the patient may be having multiple issues saying that I have multiple hypoglycemic episodes, and the patient may be having glucose values going up to 300, some values going up to 50. So that's why it may not be giving us a correct reading in that point and in that type of patient. Also, we know that when we have a patient who has many postprandial hyperglycemias, but as I said, that like they may have hypoglycemias or they may have in between excursions. So overall average may not give us a clear picture, and we may not get to know where the glycemic problem is, control problem is happening. So those are the patients where we may not be able to get the correct picture from the HbA1c, and also to understand that there are a few other group of patients, like patients who are having renal disease or liver disease, where HbA1c sometimes may not give us a good picture, and there we rely more on the monitoring of with the SMBG or with the CGM to take an idea about the things. And also there are another group of patients where they may be having some anemia or some reason or hemoglobinopathies where HbA1c may not give us a correct picture. So when we talk about glycemic glucose variability, it has two components. Basically, there are hyperglycemic spikes and hypoglycemic troughs. So hyperglycemic spikes are one thing and troughs are one thing. So there are two things. So in between, there can be a standard thing where the patient's control is well maintained. So we need to see this, both these things, and that is what we are trying to check or see from the glycemic variability. So when we talk about an optimum glycemic control, we talk about fasting blood glucose, we talk about postprandial, we talk about HbA1c, and we add the fourth dimension, that is the glycemic variability. So when we talk about glycemic variability in type 2, we know that even if it is a type 1 or a type 2, what happens that there is increased oxidative stress secondary to the glycemic variability. There is more production of free radicals, and also we know that there are more inflammation and inflammatory markers which are formed. So all these things actually cause more of problems with the complications which can happen over a period of time in these patients. So we have to understand that glucose variability in any form in a diabetic patient is not good, be it a higher fasting glucose or a postprandial glucose or higher HbA1c or more glucose fluctuations. This is what we call as the glucose tetrad concept, where we say that there is a lot of glucose fluctuation which can lead to activation of the oxidative stress, whether it is a rise in the fasting or the postprandial or the HbA1c. All these predisposes the patient to the risk of complications, as a result of which the patient may look good control, but there may be overall not a good control and the patient may land up with multiple complications. So meaning to say is, whenever the patient has more of fluctuations, be it in any form of the glycemic level, be it a fasting or a postprandial, or the HbA1c is high, or the patient has more of hypoglycemias, all this contribute to more of oxidative stress, more of inflammation. There's an increase in the inflammatory markers, and the patients get predisposed to development of complications. Now, before we proceed ahead, we should understand that what exactly is glycemic variability, how we judge that or how we monitor that. Now, we have various metrics, but we have to understand that it is basically a glucose fluctuation which we are trying to monitor. And this has two dimensions. One is the amplitude and one is the time. So we can have an intraday or an interday. So we know that if we try to see that within 2 days, how much is the difference in the glucose values on the same time, on the same day, or in a particular day between last 3 hours and next 3 hours, how much is the difference in the glucose excursion. This can also be called as a glycemic variability. So we know that we have to also see along with that how much of the time the patient has spent in hyperglycemia and how much of the time the patient has spent in hypoglycemia. This is typically what we call as the time above range and the time below range. And the range we can set for individual patients, not necessarily that you need to set a range of 70 to 180 for everyone. You can be more stringent for some patients. You may not like the glucose values to cross 160. You can be a little bit less stringent and where you may like to keep the glucose values between 70 to 140. So, or you may like to keep up to 200 as well. So it may depend on individual patients, but an average what is normally kept is 70 to 180. Now you can see here there are two different types of patients and you can see what is happening to the glucose values in a 20-hour period. So you can see that if you see the mean and the standard deviation, you may see that the patients may look like having an ideal mean and an ideal standard deviation with identical ones. Like the patient may have a mean of 7.5. The other patient is also having an identical mean glucose that is 7.5. And the standard deviation is also 2.5 for both of them. So both look identical. But if you see the mean amplitude of glucose excursions is very much different in the two patients. So one patient is having one time, like in a lot of time, the patient is spending in a lower value, and a lot of time the patient is spending in a higher value. And the other one is having excursions, highs and lows continuously. So this is how you can see that the two patients may look to have a same average. But when you see the amplitude of the excursions of one patient and compare it with the other, you may see that there is a marked difference and the patients are having two different types of excursions and both the patients may be having their own sets of the adjustments which may be needed. So one patient you are seeing is having continuously hypo, other one is having continuous one lower and then goes steadily rising up and then again higher. So both patients may look identical when you do a mean glucose, but when you actually see their CGM values, this is how they will look like. So it is very important that, like, if you see here, there are two identical patients, HbA1c, like HbA1c, you can see that patient's HbA1c is 8 in both the cases, looks identical. And when these two patients come to your OPD, and if you have not done a CGM, you may see that both are looking same, both have the same type of an average. But when you see their glycemic variability, then you can see what's happening. In the patient A, you can clearly see there is a high glycemic variability. The patient is having a lot of excursions, many highs, many lows. And you can see the second patient, that is a patient B, where the glycemic variability is not so much. So this is a patient who is less predisposed to get complications as compared to this patient, though both have the identical HbA1c. So that is why we are talking in terms of glycemic variability also, because sometimes you may see patient may come with a HbA1c of 7, and that may be the same for last 8 years. And patient might have got all the complications of diabetes. Then patient might ask you, my glucose was okay control, why I got so many complications? The other family member of mine who always had HbA1c same as mine, never got complications. So the answer is maybe this patient had more of glycemic variability. So though he may be looking controlled, but actually what is happening is he is having lots of highs and lows, which is leading to a lot of oxidative stress, and that is leading to lots of problems in this patient, and that is why this patient is getting the complications. We have multiple parameters of glycemic variability, like standard deviation. We may have the coefficient of variation. We may have the mean amplitude of glucose excursion. This is the most widely studied. And then we may have different other parameters like continuous overall net glycemic action, which we call as CONGA. And then obviously we know the self-monitoring of blood glucose, SMBG, we all know. So there are different methods, but one of the things is the mean amplitude of glycemic excursions is the one which has been widely studied, and the standard deviations which have been commonly reported expression for the glycemic variability. And also we have MODD, then we may have like mean of the daily differences, that is what we call as MODD. Then we have a visit-to-visit glycemic variability. Then we have the standard deviation of the fasting plasma glucose over weeks to years, which can tell us about the long-term glycemic variability. Then we have the standard deviation of the HbA1c over months to years, again, which can tell us about the long-term glycemic variability. Now, what are the implications? Why it is important? Because we know that if the patient has more of glycemic variability, the occurrence of hypoglycemic event also may be more. We know that glycemic variability means what? The patient is getting highs, lows. So there's a lot of fluctuation. So these patients may have lots of hypoglycemic episodes. So it has been seen that if there is a higher glycemic variability, it actually doubles the occurrence of the hypoglycemic events. Also, there is a definite correlation, and studies are available now where they have tried to see the glycemic variability and its correlation with microvascular complications. And it has been seen that glycemic variability is associated with different microvascular complications, including painful neuropathy. Also, has been seen that patients who have more of glycemic variability, it has been seen in some of the studies that it is associated with higher or longer length of stay in the hospital, and also mortality in non-critically ill hospitalized patients as well. So other important thing, because sometimes the patient is admitted in the hospital and you see that there is a lot of variability which is happening in this patient. So you know that this patient may land up with longer stay in the hospital and may have a higher rate of mortality as well. Another thing which we need to understand is glycemic variability is also associated with cardiovascular health. So it has been found to be an independent predictor of cardiovascular mortality also. So we also need to understand that not only the microvascular, but also the macrovascular complications have been found to be associated with glycemic variability. Now, these are some of the studies which have tried to see the impact of the glycemic variability on the cardiovascular outcomes in type 2 diabetes patients. Like you can see the ADVANCE, the DEVOTE, and we know that we had the outcomes for MACE and severe hypoglycemia. If you see the ADVANCE, we know that they were trying to see some of the metrics like fasting glucose and HbA1c and the visit-to-visit variation. They were trying to see the coefficient of variability. And then they were trying to see in the another VADT, you know, that fasting glucose and HbA1c. And there are DGAMI study and all where they were trying to see the blood glucose and they were trying to see the association with the mortality, stroke, and reinfarction. So there are lots of studies. They may not have typically done the CGM, but they have tried to see some of the metrics of the glycemic variability, including the SMBG, also CGM in some studies where they have commonly tried to see MAGE, that is the mean amplitude of glucose excursions, the standard deviations, the coefficient of variation, also the HbA1c difference in the visit-to-visit, like in ADVANCE, where they have tried to see the variation of these and their correlation with the macrovascular. And also some of these studies have also seen microvascular as well. So basically what we are trying to show here is that glycemic variability is not only going to cause more of problems with the quality of life, it is also going to cause more of problems with the microvascular as well as the macrovascular complications. So we know that if you see, obviously, when we try to make a patient under good control, we try to have individualized targets for all our patients. So we can't say that we have a HbA1c 6.5 for all my patients, yes, but if I'm able to achieve it without causing much hypoglycemia, I will try to achieve a 6.5 in a younger patient with no comorbidities. But if it's an older patient with comorbidities, I may be okay with a little bit higher HbA1c, because I would try to prevent the hypoglycemia also, and also see that the patient does not get much of glycemic variability as well. Now, there are different studies where they have shown that obviously hypoglycemia is one of the major things which patients are always worried about, and we are also worried about whenever we start insulin or give any drug which can have a propensity to cause hypoglycemia, like SUs as well. So we are always worried about this thing when we are starting this for our patients, because not only it causes a lot of morbidity, can lead to mortality as well, and can also lead to non-compliance and problems with the quality of life. A lot of cost comes into play. So all these things are a very important factor. And we know that there are studies which have not, like some studies have shown that intensive therapy may not be very beneficial, and because of the higher incidence of hypoglycemia. So what we have got to know from these studies is that if a patient is younger, has no comorbidities or has almost minimal comorbidities, and has not much of complications, you are justified in doing an intensive control. This is what Advance and Accord have taught us. But if a patient has longer duration of diabetes, and patient has already got the complications, and if you're trying to do too intensive a control, you are not going to do any benefit to that patient. So basically, if we have to have our individualized targets for most of our patients. Now we know that hypoglycemia itself can be one of the major factors, or it can be related to immediate cardiovascular mortality as well. We know that hypoglycemia can cause some rhythm abnormalities. It can cause lengthening of the corrected QT interval. It can cause more of heart rate variability. So that is why we need to minimize the glycemic variability. Both highs and lows are bad, so we don't want that. So how can we do that? Obviously, we have to see that the patient takes some diet on time, exercise is streamlined. They take even if for our type 1s, we also need to see that they take the snacks on time, their exercise snacks, and they check the glucose values post that. And also our type 2 diabetics on insulin, we have to see that if they're doing exercise, they have to check their glucose values, and we have to decide the snacks if needed for them. Then comes the therapeutic modification. So we need to have some of the therapeutic modifications which we need to do for these patients to reduce the glycemic variability. So obviously, we will try to use drugs which can cause lesser risk of hypoglycemia, because whenever we talk about diabetes management or an ideal anti-diabetic drug, the first thing which is there, that the drug should be having a lesser or a almost minimal potential to cause hypoglycemia. And then we talk about the next step, that we say that the drug should be causing a good glycemic control or should be good anti-diabetic drug as well. So the first point which comes is the drug should not cause hypoglycemia. So when you see, obviously, drugs like SUs have a higher incidence of causing hypoglycemia as compared to drugs like gliptins, which don't have much propensity to cause hypoglycemia, because we know that the incretins are secreted in response to increased glucose levels in the blood. And if the glucose levels are lower, the incretin hormones will not be secreted. And DPP-4 inhibitors actually work by blocking the DPP-4 enzyme, which cause degradation of the incretin hormones. So if the hormones only are not secreted, we will not have a higher propensity to cause hypoglycemia with these drugs. We know that drugs like vildagliptin have a very less propensity to cause hypoglycemia. And in this study, they were trying to see the minimization of the risk of hypoglycemia with vildagliptin. And they were trying to see that what they did was they tried to see the treatment with vildagliptin versus placebo in a double-blind crossover study on the glucagon response to both hyper and hypoglycemia. And what they found was the study showed that vildagliptin increased the glucagon increment during the hypoglycemic time, yet reducing the postprandial glucagon area under curve by 41%. So vildagliptin was found to improve the action of glucose to suppress the glucagon secretion during hyperglycemia, which was seen during the meal ingestion, and augmenting the effect of hypoglycemia on glucagon secretion, which was seen during the steeped hypoglycemic clamps. We definitely are talking today about the use of drugs like DPP-4 inhibitors, including like vildagliptin, in reducing the glycemic variability. If you see the effect of gliptins on glycemic variability, you can see here clearly that DPP-4 inhibitors have been shown to reduce the mean amplitude of glucose excursions as compared to the other oral anti-diabetic drugs. So you can clearly see here it favors DPP-4 inhibitor as compared to other oral anti-diabetic drugs. So the common drugs which have been used in these studies are SUs, and they have also tried to use meticlinides. So the comparison is mostly with that. And what we know is definitely DPP-4 inhibitors fare better. And here they have tried to see the glycemic control and variability by doing a 4-point preprandial self-monitoring of blood glucose. This was with 29 patients over a 4-week treatment period, and they have tried to see the different metrics and calculated that, and they have tried to see the conga, the J index, which is the mean glucose, plus you can have the standard deviation added to that with the mean amplitude of glucose excursions. And obviously what they have seen that it was found to be lesser, and the indices with the vildagliptin were found to be better for the glycemic variability as compared to the placebo. And if you see the gliclazide comparison with DPP-4 inhibitor like vildagliptin on glycemic variability, this is a CGM data. And again, they have tried to see that there was a definite betterment of the CGM parameters as regards to the glycemic variability with the use of vildagliptin as compared to gliclazide. So again, it has performed better in the glycemic parameters or the control of the glycemic variability metrics as compared to SUs. So this was the OPTIMA study where they have tried to see and shown that vildagliptin provided a 24 hours better glucose fluctuation control as compared to glimepiride also. And what they have tried to see that the study did definitely show that glimepiride caused more fluctuations as compared to the DPP-4 inhibitors. And if you can see here, the comparison of the OPTIMA CGM, they found that there was a significant decrease in the basal hyperglycemia area under curve with vildagliptin compared to sitagliptin. Now this, they have tried to see the change with sitagliptin versus vildagliptin, and they have tried to see that there was a betterment with the vildagliptin as compared to sitagliptin at week 8. And again, they have tried to see the hyperglycemic exposure with vildagliptin and with versus sita, and again they have found that vildagliptin fared better as compared to sitagliptin. So what they said that addition of DPP-4 reduced the glycemic variability, but also they found that vildagliptin induced a better circadian glucose control than sitagliptin. And the main difference between the two treatment groups was seen overnight between midnight time, and while the magnitude of the decrease in the peak following breakfast was almost similar between vilda and sitagliptin. So what they found that the decrease was seen during the overnight period, and vildagliptin induced a decrease in the minimum blood glucose reading during the night, and which was well above the threshold of hypoglycemia. So daytime, they did not see much difference, but in the midnight, they found that there was a difference in the treatment group. And again, they have also tried to see the effects on glucagon with vilda compared to sita. And this was a head-to-head study where they have tried to see, and they found that obviously here also they have shown the same thing, that vildagliptin maintained a better 24-hour glucose control and with much better glucagon control as well. And they also tried to see the reduced 24 hours acute glucose fluctuations, that is the mean amplitude of glucose excursions with the use of gliptin. And here they have again tried to see the reduction of the oxidative stress and inflammation by blunting the daily acute glucose fluctuations in patients with type 2 diabetes. Though they are taken by around 90 patients with metformin dose of 2 grams, with vildagliptin 50 twice a day, with sitagliptin once a day, and the baseline HbA1c was more than 8.2, and they were trying to see the glycemic variability. And again, they have tried to see that it was betterment was seen with the use of vildagliptin as compared to sitagliptin. So here they have again tried to see the oxidative stress markers, and they have also tried to see some other inflammatory markers like interleukin-6 and interleukin-18, and they found they were all lower with vilda as compared to sitagliptin. And by blunting the daily glucose fluctuations, they have again tried to see the changes in the mean amplitude of glucose excursions, and again the oxidative stress markers, interleukin-6 and 18. This is again, they have tried to see that vildagliptin fared a little bit better in most of these parameters as compared to sitagliptin. So in this study, this was a 16-week trial where they were trying to see vildagliptin or pioglitazone effect on glycemic variability and oxidative stress in type 2 diabetic patients who are inadequately controlled with metformin monotherapy. And again, you can clearly see here with baseline and 16 weeks with vilda, and you can see the mean amplitude of glucose excursions and with the pioglitazone as well, baseline and 16 weeks. And you can see that it was significantly reduced with vilda with a p-value of 0.04, while pioglitazone was not significant with a p-value of 0.09. So vildagliptin reduced the glycemic variability in individuals with type 2 who were inadequately controlled with metformin monotherapy, and this was a 16 weeks trial. So what we have understood is glycemic variability is definitely the fourth dimension and one of the important dimensions in type 2. And it's not necessary that for glycemic variability, you need to do only CGM or put the sensors. You can do it with SMBG monitoring. You can do it with HbA1c comparison with the previous visit and the visit now. You can do it with the comparisons of the glucometer monitorings done on different days and at different points of time. So it is very important that we understand the concept of glycemic excursions and variability, because the HbA1c itself may not give you the correct picture for many of our patients because you may miss the fluctuations. So that another thing is what we can do with the glycemic variability monitoring is we can try to avoid the hypoglycemia. Talking about drugs like the DPP-4 inhibitors, including vildagliptin, which we talked about today, we know that these drugs have a very low propensity to cause hypoglycemia. Also, there are studies now with vildagliptin, and it has been compared with SUs, some of the other DPP-4 like sitagliptin as well. And they have shown that there may be lesser of the glycemic variability with drugs like vildagliptin. And also there may be reduction in the oxidative stress, because we know that more the glycemic variability, there is more propensity to get microvascular as well as the macrovascular complications as well. And we also have seen that it has a better circadian control of that glucose levels. So what we need to do is we need to adjust and do the therapeutic modification for most of our patients who come with more of these hypoglycemias and hyperglycemias. It may be many drugs which may be used for those patients, and even some of them may require the adjustment of insulin dose as well. So all that needs to be done to reduce the glycemic variability. Thank you.
Thank you so much, Pramila, for that very clear and nice talk. There are no questions in the chat box, but I'll just ask you one question. Have you found any difference in glycemic variability with vildagliptin BD versus the OD preparation that is out?
Absolutely. I still prefer using BD preparation. I am more comfortable and my patients are doing pretty well with that. I tried shifting some of my patients initially from BD to OD, and I did find that there were problems with the excursions which were happening in the evening and the night time. So some of them I've shifted back to BD. So I am still more comfortable using BD dose as compared to the OD sustained release which has come up, because I see a better control with the BD still.
Right. Thank you, Pramila. Thank you so much. Yeah, yes, sir.
Pramila, good talk.
Thank you.
One observation and comment from you I want. See, the DCCT study showed that glycemic variability was not really a indicator for the complication. It was the HbA1c. The Idec which followed up also showed the same thing. And what they found was glycemic variability in ICU setting is very important.
Absolutely.
Your comments on that?
Yeah, actually, I agree with you. But over a period of time, I agree with the DCCT and the Idec data. But what we have seen over a period of time, what new data has come up, though I would not say that it is a very robust data to comment on, not like the DCCT standard. But yes, we have new data coming up now where they have tried to see the oxidative stress markers with the glycemic variability. And now we know that if you see the concept of diabetes treatment itself is changing over a period of time. And now if you see, we try to see more of diabetes as an inflammatory disease and inflammatory markers, oxidative stress. So all these things have been shown now, and they have tried to see the microvascular as well as the macrovascular correlation. And if you see the data from the advanced and those studies where we have extrapolated that fasting plasma glucose or the HbA1c variability, and they have tried to correlate it with the complications. So we are getting a trend towards that only, that these glycemic variability would be an important metric. This is still, we need to have more data, I would say. But whatever studies we have shown a positive correlation between the glycemic variability and the microvascular complications as well as the macro as well. So I think it's an important metric which we need to study in more number of patients, and maybe then we can have clarity on that. That's how I look at it.
Thank you.
Thank you.
Thank you so much, Pramila. And now we are going to do our next talk in the drug reviews and therapeutic session. And for this, we have none other than Dr. Vijay Panikar. And everyone knows Dr. Vijay Panikar, but it is my proud privilege to introduce him. And he is going to be talking about early use of combinations in diabetes and hypertension with a focus on cilnidipine. So Dr. Vijay Panikar, as we all know, is in Mumbai, and he's the founder and director of Dr. Panikar Specialty Care Center located in Dadar and Bandra East. He brings with him years of clinical expertise and training in this field and has successfully managed a comprehensive spectrum of endocrine and diabetes cases over the past 3 decades. He is an active professor of medicine at the KJ Somaya Medical College, Sion, Mumbai. And he's also an honorary consultant with the Department of Endocrinology, Diabetes and Metabolism at Leelavati Hospital and Guru Nanak Hospital, Bandra, Mumbai. He has many feathers in his cap, many accolades and many awards. And basically, he is an extremely popular person and an inimitable style of speaking and a wonderful orator. So over to you, Dr. Vijay Panikar, sir.
Thank you, Neeta, for a very kind introduction. And I must thank the entire Idec team for putting up this fantastic program. Can you see my slides?
Yes, sir.
Yes. The topic given to me is early use of combination in diabetes and hypertension, focus on cilnidipine. See, diabetes is a major risk factor. Hypertension is a risk factor for diabetes, and diabetes is a risk factor for hypertension. Uncontrolled hypertension can cause atherosclerotic cardiovascular disease, the whole works, macrovascular disease. Uncontrolled diabetes may cause various macro and macrovascular complications, and hypertension is the second most important cause of chronic kidney disease after diabetes. So both uncontrolled hypertension and diabetes can cause serious cardiovascular complications and many other complications. And then you can think how dangerous this combination will be. Hypertension with diabetes, two deadly diseases out there to damage your patients. Hypertension is twice as common in diabetics. In fact, 50% of diabetics will have hypertension and 50% of hypertensives will have diabetes. New onset of diabetes 2.5 times in hypertension, 20 to 40% of IGT patients have hypertension, up to 75% of type 2 diabetes have hypertension. And 1/4 of hypertension in diabetes is not controlled. I would say more than half are not controlled. And hypertension with diabetes increases the cardiovascular risk threefold. Now, at the time of diagnosis, 50% of diabetics have hypertension. But as the duration of diabetes progresses, that number can go up to over 70%. So hypertension is an integral part of being a type 2 diabetic. Now, when you talk of hypertension and diabetes, they are partners in crime. Type 1 diabetic, hypertension is usually a renoparenchymal in origin. And it is caused by the underlying diabetic nephropathy which develops over a time in type 1 diabetics. They generally don't have hypertension at the time of diagnosis. And this typically manifests when the patient starts presenting with a renal abnormality, which is checked out with a microalbuminuria. As opposed to that, type 2 diabetes is multifactorial, mainly due to insulin resistance as a part of metabolic syndrome. And usually, hypertension can precede the onset of nephropathy and even the onset of diabetes by years or decades. Now, when you talk of the complications, hypertension can affect the brain, hemorrhage, stroke, retinopathy, peripheral vascular disease, renal failure, of course, and cardiovascular morbidity. Now, whenever hypertension is with diabetes, the chances of complications definitely increase. Cardiovascular mortality rate, if you see, yellow is diabetic, the purple is non-diabetic. For every level of hypertension, the diabetic is more prone to cardiovascular risk. Same way with systolic hypertension. These are non-diabetics, but the moment you have diabetes on that systolic, same systolic hypertension, the complications practically double. Now, CV risk mortality doubles for every increase of 20 by 10 millimeters of mercury. See this here, 115, 75, 135, 85, double, it goes on increasing, and that is how the BP will cause the problem. So there is substantial evidence that supports the benefits of BP reduction in patients with diabetes to reduce the major macrovascular, microvascular complications of diabetes, as well as mortality and morbidity in diabetic patients. And the proven benefits of BP lowering treatment in diabetes also include significant reduction in the rate of end-stage renal disease, the onset, progression, duration, retinopathy, and albuminuria. So hypertension treatment is very important. Let us look at some of the studies which looked at the diabetic patient. This is the HOT study which looked at bringing down the diastolic blood pressure from 90 to 80. Very significant reduction in major cardiovascular events, myocardial infarction reduced, CV mortality reduced. But look at this. These are diabetic patients, these are non-diabetic patients. Reduction from 90 to 80 causes a 48% risk reduction, but that doesn't reflect in non-diabetic patients. That tells us that treating hypertension in a diabetic patient is a very rewarding and fruitful result. These are the summarized thing about the HOT study. Major cardiovascular events reduced by 50%, cardiovascular mortality 67%, and stroke 30%. Now, whenever you have a tight hypertension control, the rate of progression of the decline in eGFR is reduced. See, this is your BP of 130 by 85, and this is the GFR reduction per year. As the BP increases, untreated diabetes goes to maximum, telling us that a good hypertension control is mandatory in all diabetics. This is again a study from the UK PDS, which compared tight blood pressure control versus tight glycemic control. And what was the glycemic control? HbA1c around 6. Goal was, the average blood glucose of 108. But tight BP control was just 144 by 82. And look at that, stroke reduced by 44%. Any diabetes endpoint, 24% as opposed to only 12% and 5% in stroke. Diabetes deaths, 32% reduction as compared to 10%, telling us that in a diabetic, treating hypertension is definitely more important. I'm not saying that glycemic control is not important, but the results and the outcome are much, much superior when you have a good blood pressure control, obviously with a good glycemic control. Now, kidney damage and severe risk. So as the kidney damage progresses, normotensive, glomerular filtration rate, kidney failure, as it goes on increasing, the chances of cardiovascular mortality goes on increasing as the GFR comes down. Intensive versus standard BP lowering. All the major guidelines recommend blood pressure target of less than 140 by 90. There is recent evidence that in patients with CKD, lower the BP, the better the outcome. Now, these are some Indian guidelines in 2019. What should be the threshold for starting diabetes treatment? In a diabetic, any BP greater than 140/90 becomes a threshold for treating diabetes. And what should be the goal? 130 by 70 to 80. These are again guidelines from ESH and AHA and ACC. There again in diabetics, it says get it down to below 130 by 80. Why treat early? Data for grade 1 hypertension patient with low to moderate severe risk from 10 RCTs which were analyzed. And all of them, treated patients showed definite benefit. So pharmacological treatment was associated with a significant reduction in coronary artery disease, stroke, cardiovascular outcome, all-cause mortality, and renal failure. Now, what is the problem? Even in the best performing countries, more than half of the hypertensives are never properly controlled. And majority are still treated with monotherapy, which will never be adequate in BP control, especially in diabetics. So combination of BP lowering drugs are required to control BP in most patients with hypertension. Is there any ideal combination for use? Look at these studies. These are so many studies which looked at patients to achieve target BP goal. And if you look at the number of BP medicines, all of them needed at least 2 drugs to control their BP. And why this poor BP control in diabetes? Because there is activation of RRA system, volume overload, sleep apnea associated obesity, vascular damage, and there is a clinical inertia. There is a failure to increase the drug dose. You find somebody's BP is 140, 100. You say, oh, this could be a white coat effect. Let's check it again. Let's do it again. And in that process, it goes untreated because the follow-up does not come. And that is where the problem starts. So the goals of management would be lower the BP, which will minimize proteinuria, eGFR decline is slowed, and reduction of progression of CKD and cardiovascular disease. Now, this is the 2020 ISH global guidelines, which says you should start drug therapy with a single pill combination, low dose ACE-ARB with a calcium channel blocker. And choosing the ideal combination therapy for hypertension and its related organ damage, again, a calcium channel blocker with a RASI inhibitor. And that causes a greater reduction in mortality. So what is the recommendation, ESH and ESI? Initial one pill combination would be an ACE or ARB with a calcium channel blocker, or an ACE or ARB plus a diuretic or a loop diuretic. Second step is a triple drug combination, is an ACE or ARB with a calcium channel blocker plus diuretic. And third is resistant hypertension, where you may add a spironolactone. But if you have an ACE or ARB on board, be careful about adding a spironolactone because that can cause hyperkalemia. You can use diuretics, alpha blockers, beta blockers. Now, beta blockers should be considered at any step where there is a specific indication for its use. Example, patient with cardiac problems, heart failure, angina, post-MI, atrial fibrillation, or younger patients who are planning pregnancy. That is where the beta blockers would come in a diabetic hypertension. Now, these are the ESC guidelines, which says that start early. To achieve BP goal, most patients will require a combination therapy. They are safe, well tolerated, shorter time to target, and longer period of control. So what would be the choice of antihypertension? The first line, obviously, is an ACE or an ARB. But in this, please watch out for hyperkalemia and hypotension, because patients who are on ACE or ARB, the moment they go into severe hypotension, especially if they have a gastroenteritis or a loose motion or something, they can go into acute kidney injury and acute kidney failure. Second line is calcium channel blocker and diuretic. Third line is beta blockers, alpha blockers, and so on. You should add on combination rather than replace. You don't change one and add another, but you add on. So to simplify the combination therapy, these are the three groups: ARB, diuretics, and calcium channel blocker. Now we are going to talk about calcium channel blockers, and there are certain unmet needs. All calcium channel blockers are not renal safe or renoprotective. Most of the calcium channel blockers are short acting or short lasting. And there is a reflex tachycardia as a major side effect. Now there are different types of calcium channels. You have the L-type or long-lasting. L-type currents are long-lasting, slow in activation rate, and are blocked by all the calcium channel blockers. You name them, all of them act on the L-type. They are found in cardiac and vascular tissues, and they're absent in renal tissues. The N-type, that is the neuronal type, currents are found primarily in neurons, where they initiate neurotransmission by releasing norepinephrine from the peripheral sympathetic nerve endings. They are also present in renal tissues. So there is a release of norepinephrine. The T-type, this is transiently activated. This is not very active. T-type currents are transient and they're present in renal tissues. And you have the P or Q type, they are neuronal types of calcium channel blockers recently detected in the arterioles. Now, if you look at the currently available calcium channel blocker, nifedipine, amlodipine, ephedrine, nilotinib, azildipine, benidipine, and cilnidipine. Cilnidipine is the fourth generation calcium channel blocker. They all block the L-type. And what does that blockage cause? Decrease in contractility of the heart, actually increase in the heart rate, pulse rate increases, and the glomerular pressure increases. This is what L-type activation causes. Blocking of T-type does very similar thing, but could reduce aldosterone secretion. The N type reduces the heart rate as opposed to increase. There is no reflex tachycardia. Glomerular pressure is decreased, and that is where the advantage comes in preventing the progression of nephropathy. If you look at all the calcium channel blockers, cilnidipine is the fourth generation. The norepinephrine levels are all increased with the L channel blockage. But with the N channel, there is no change or decrease. Heart rate is increased by all of them, no change. Characteristic rapid action L. Now let us look at cilnidipine nephroprotection. What are the studies that we have? This is the antiproteinuric effect of cilnidipine added to an ACE or ARB, and the urinary protein creatinine ratio was suppressed in cilnidipine group, but amlodipine group did not have an effect. Cilnidipine significantly reduces proteinuria unlike amlodipine. Look at this is a 12-month study comparing amlodipine and cilnidipine. With amlodipine, there is an increase in proteinuria. With cilnidipine, there is a decrease. Uric acid is also reduced by, because this increases the uric acid excretion. Telmisartan is superior to losartan, accepted. But here, this is an Indian study comparing adding cilnidipine to telmisartan versus amlodipine to telmisartan. And they're looking at the percentage of increase in proteinuria from baseline. Cilnidipine and telmisartan and amlodipine and telmisartan, there is an increase. So cilnidipine is beneficial there, mainly because it reduces the intraglomerular pressure. Pedal edema. All calcium channel blockers can cause pedal edema. Amlodipine, 70%, cilnidipine, 26%, significant less. So cilnidipine and telmisartan associate greater suppression of the increase in proteinuria as well as associated with lower incidence of pedal edema. Changes in urinary protein creatinine ratio, proteinuric effects are superior in cilnidipine group compared to the amlodipine group. Again, same here, cilnidipine reduces albuminuria. This is an Indian study which was just published this year, 2021. After 6 months, there is a significant reduction in albuminuria. Cardioprotection studies, cilnidipine significantly reduces carotid femoral pulse wave velocity. Now, tachycardia, reflex tachycardia is more with amlodipine, much less with cilnidipine. TDI is a tissue Doppler imaging. Cilnidipine improves left ventricular function in hypertensives. There is surprisingly a beneficial effect of cilnidipine on the lipid profile also. Reduces triglyceride, increases HDL by 5, reduces the VLDL, total cholesterol is also reduced. Now, we have the different calcium channel blockers. What is the comparative data that we have? This is comparing with azildepine. Azildepine is a L and T suppressor. This was published in 2013. The results suggest that cilnidipine is more efficient in reducing albuminuria than azildepine, independent of its blood pressure lowering effect in type 2 diabetic patients with hypertension. This was a study of the new 4 types of calcium channel blockers. They were nifedipine control release, cilnidipine, ephedrine, amlodipine. And what did this study tell us, or did they find? It revealed that only nifedipine control release and cilnidipine could reduce albuminuria statistically. Thus, it was suggested that the 2 calcium channel blockers would be favorable for organ protection in hypertension. Nifedipine control release, or the nifedipine retard preparation that we have, not the plain nifedipine. Now, this is again comparison with benidipine. Benidipine is the only calcium channel blocker which blocks L, N, and T. And it has a slightly better reduction in protein excretion. So, urinary protein creatinine ratio significantly decreased in both groups after 3 months of therapy and thereafter. However, the difference between the groups was not significant after 12 months of treatment. And conclusion, the addition of benidapine as well as cilnidipine reduces urinary protein excretion in hypertensive patients with CKD who are already being administered ARBs. This is very important. They work beautifully when they are given in combination with an ARB. So to summarize, blood pressure lowering remains a key objective for treatment of hypertension. There is no question. It is the most rewarding therapeutic option which we have in treating type 2 diabetes. Good blood pressure control, obviously along with a good glycemic control. There is still under detection, under treatment, and suboptimal BP control in India. Medical inertia. I have had experiences where there was a patient who had a BP of 150/90. I put him on medication and his family doctor tells the patient, "Arey, tumko blood pressure nahi hai, mat lo goli." This is lack of knowledge and lack of applying what is required. So poor BP control will give you poor clinical outcomes. And the real challenge is to improvise effective, simple, and safe medication. Most people need drug combination, no question about that. Most of your antihypertensives, 90% of your diabetics will need at least 2 drugs, and that would be an ARB and a calcium channel blocker. Combination of ARB and calcium channel blocker is likely to be the best tolerated, most effective, most protective, and the preferred combination for most patients. Thank you very much, ladies and gentlemen. Thank you.
Thank you very much, sir, for that very illuminating, clear, and nice talk. I don't see any questions in the chat box, but I would like to ask one question.
Sure.
Considering the all the attributes that have been given to cilnidipine, and you've very nicely shown us the different L type and N type and all of that. Practically speaking, do you think we should change over all our amlodipine patients to cilnidipine?
See, amlodipine is also a good drug. The main thing is, if there is a proteinuria, then you should be shifting over from amlodipine to cilnidipine in combination with an ARB. If there is no proteinuria and his BP is well controlled, his sugars are well controlled, you could continue with amlodipine. There is no problem.
Right.
It's a good drug by itself.
Right.
But
Yeah.
cilnidipine definitely has advantages in patients, diabetic patients who have proteinuria.
Right. If patients do not have proteinuria, do you think the BP reduction potential differs with amlodipine and cilnidipine?
It's comparable. It is comparable.
Right.
It is comparable.
Okay. Are there any other questions?
But if you
Yes.
ask my personal opinion, I think
Yeah.
amlodipine is more potent in
Yeah.
BP reduction than cilnidipine marginally.
Margin. Right.
But that is not saying anything actually.
Yeah. Yes. Yes. Anybody has any other questions, Dr. Makkar? Anyone wants to ask? We still have a little bit of time, so that's why.
So just to come back to the diabetes and hypertension, we have not had any concrete kind of recommendations coming in last almost a decade. There have been plus points and minus points, and if you, I don't know whether you listened to George Bakri's last evening, he did a very nice practical talk on how to approach hypertension, and he had a lot to say about azilsartan as one of the important things. And according to him, according to the guideline now that is there, we should be looking at combination of ARBs or ACE with calcium channel blockers and diuretics. So how frequently you think we should be using, how frequently you need to use this triple drug combination, or you still prefer to use higher dose of one drug and then add second dose?
Generally, I do use a telmisartan CCB combination quite frequently. In fact, that would be my top of the line at the moment. Very rarely do I need to use a triple with a diuretic, because in the current scenario, we are already with SGLT2. So you don't need a diuretic push. SGLT2 also brings down the blood pressure to some extent. And in many of the patients I am seeing, I have to reduce the antihypertensive when the patient is on SGLT2. So that is the current scenario in my practice. I have been seeing that I have to reduce the antihypertensives.
So how much is the concern of using diuretic in diabetes patients, particularly the thiazide group?
No, it is not a concern. Where it is required, you definitely use it to bring down the blood pressure. It is the third thing. You have a ARB, you have a calcium channel blocker, you have a diuretic. If with two, the blood pressure is not controlled, you definitely add on a third. There is no question about that. It is definitely a part of the armamentarium.
Thank you. Thank you very much, sir, for that nice interaction also.
Thank you.
Thanks for being a part of IDEC. And
Thank you.
we now move on to the next talk, a very interesting concept, quite new, and a lot is being talked about it. We are going to be talking about mitochondrial modulators striking at the heart of type 2 diabetes complications. And for this, we have Dr. Makkar. He spoke about mitochondrial flexibility and mitochondrial modulation in a very beautiful talk that he himself gave at the ACCD recently. And we're very eager to listen to this. He has already been introduced, but for people who have logged in for the first time, Dr. Brijmohan Makkar is a leading senior diabetologist and obesity specialist in India. He's from Delhi. And his areas of interest are diabetes, obesity, and metabolic syndrome. And he's the founder member of Delhi Diabetic Forum and has been office bearer in various capacities. And he is also a member of the executive board of Diabetes India, and he's a member of the RSSDI and has served in various capacities at the RSSDI. So over to you, Dr. Makkar.
Thank you, Dr. Neeta. Good morning, everyone. Once again, it's a pleasure to be at IDEC platform, and thanks for the opportunity. And I am, shall I share my screen?
Yes, please.
Okay. So this is my screen. So I am going to speak on mitochondrial modulators striking at the heart of type 2 diabetes complications. Now I have done a little, tweaking in the title because I think it's too early to talk of modulators. More important is the concept, and that's how I'm going to address this. So I'm talking on mitochondrial modulation, more focus on this rather than the interventions. I don't have any disclosures for this presentation. In this presentation, I'm going to speak about mitochondrial dysfunction and metabolic inflexibility, which is a very important concept that we are learning now. How does metabolic inflexibility lead to type 2 diabetes and also the increased cardiometabolic risk, and where do we see the role of mitochondrial modulators, which is possibly the new emerging area of intervention that we are going to see in next few years. So we have known for more than 3 decades now that type 2 diabetes is caused by two core defects, beta cell dysfunction and insulin resistance, leading to decreased insulin secretion on one hand, increased glucose output from liver, and decreased utilization of glucose from at the level of muscle. Till DeFronzo in 2008 proposed the concept of ominous octet, and he showed that hyperglycemia is caused by not just these two mechanisms, but there are multiple mechanisms contributing to hyperglycemia. The important thing to see here is that out of the 8 proposed mechanisms, 7 act through directly or indirectly through beta cell dysfunction and insulin resistance, except for the glucose reabsorption, which is independent of the insulin axis. Now, all these mechanisms are acting independently, or there is something which is causing this whole ominous octet. So if there is a common mechanism, what is it? What is leading to this ominous octet? So we have known from past studies that there is a complex interaction between genes, epigenetic factors, environmental factors, and lifestyle, bad lifestyle. They all contribute to development of chronic, chronic diseases with increased cardiometabolic risk, and dysglycemia is one of the major components leading to diabetes. Now, how does this all link up? Is it the mitochondrial dysfunction which is leading to all these problems? And that's what we are going to explore in this talk. So at the level of tissues and cells, the basic pathophysiological mechanism is the increased insulin resistance, which basically affects liver, skeletal muscle, and adipose tissue. At first, the pancreas compensates by increasing the insulin production to cover up for insulin resistance, but during the course of disease, it fails and leads to frank hyperglycemia. Now, because of the insulin resistance, what happens is that body acts very differently. Instead of storing and oxidizing glucose and lipids in the fed state, body and body tissues act as if they are still starving because of the insulin resistance, and they keep pouring out glucose and fatty acids into circulation, leading to a substrate overload, which leads to hyperglycemia, ectopic fat accumulation, and worsening of insulin resistance. And if you see this, this is a slide which I picked up from 2005 Medscape page. And if you see this, it clearly shows that obesity and resulting increased free fatty acids lead not only to development of insulin resistance and diabetes down the line, but also contribute to development of dyslipidemia, and hypertension, and ultimately leading to increased cardiovascular risk. And this also is, being proposed as one of the major concepts now, that it is the adiposity based chronic disease model, which suggests that complex intervention between genetics, environmental, and epigenetic factors leads on one side not only to the fat accumulation in a scenario of chronic overnutrition, but also leads to development of insulin resistance, beta cell dysfunction, diabetes, and chronic complications of diabetes on one hand, and on the other side, it leads to development of hypertension, dyslipidemia, and increased cardiovascular risk. So, the concept is clear that pre-diabetes, diabetes, hypertension, and dyslipidemia are closely interlinked. But what is the link? Are they linked because of the disruption of normal energy homeostasis? And we know that normal energy metabolism occurs largely at the level of mitochondria, and mitochondria is the powerhouse of the cell. So mitochondria produces ATP by utilizing both glucose and lipid, so free fatty acids. So there is glucose oxidation and lipid oxidation, both happen in mitochondria, and they happen depending on the physiological circumstances of nutrient supply. So in the fed state, there is an increased oxidation of glucose, and the post-absorptive phase, there is increased beta oxidation leading to production of ATP. And this, ability of mitochondria to shift between two different fuels or alternately use different fuels is termed as what is called metabolic flexibility. The normal energy metabolism is characterized by periodic shifts in glucose and fat metabolism, and the mitochondrial machinery has the ability to switch freely between these fuels depending on the physiological and nutritional circumstances. What happens in obesity or the states of chronic overnutrition? These are being increasingly recognized as states where there is loss of metabolic flexibility. When there is excess nutrient overload, which is entering the mitochondria, there is a competition between different substrates which are competing for the metabolism. And this leads to what is called as mitochondrial indecision, impaired switching of the fuels depending on the, which happens in normal physiological circumstances, and dysregulation of energy production, leading to a state of metabolic inflexibility. So once there is obesity or chronic overnutrition, there is increased supply of nutrients coming to mitochondria. This increased supply happens to be all nutrients. It's not just glucose or lipid. There is overall supply of nutrients which compete for metabolism at the level of mitochondria, causing a gridlock at the level of metabolic processes, and this is a state of metabolic inflexibility. Now, let's see how the glucose and fatty acids are normally metabolized. So, these are the two major sources of production of ATP. What happen, and both these have to enter the TCA cycle ultimately to get into production of ATP. So, what happens in fed state? There is increased glucose entering the mitochondria. There is increased glucose entering the glycolytic cycle, producing acetyl coenzyme A, which enters the TCA cycle and produces ATP. Now, in the whole process, there is this increased acetyl coenzyme A also regulates the decreased entry of fatty acids into mitochondria by increasing the levels of malonyl coenzyme A and citrate. On the other hand, in the fasting state, there is increased supply coming from the free fatty acids, which enter the mitochondria to produce TCA acetyl coenzyme A, which in turn inhibits the pyruvate dehydrogenase and decreases the entry of glucose. So, glucose and fatty acids actually reciprocally inhibit the metabolism or regulate the metabolism of each other. So, mitochondria plays a central role in energy metabolism and is responsible for oxidative phosphorylation as well as beta oxidation and is essential for glucose and lipid metabolism. Now, we know mitochondrial dysfunction has long been associated with diabetes as a potential cause of both insulin resistance and beta cell dysfunction, and more recently it is being discussed even in the context of diabetes complications. The important question is whether the insulin resistance causing metabolic inflexibility or it is the vice versa. And one view suggests that blunted glucose oxidation that happens in response to meal supply actually reflects as a consequence of insulin resistance. Now, the current view is that derangements of fuel selection are at least partly independent and may actually precede or contribute to development of insulin resistance. And in healthy state, there is a strong crosstalk between various metabolic pathways through a number of metabolites which act as the mediators of this crosstalk, like fatty acids, pyruvate, citrate, and malonyl coenzyme A, as I showed in the earlier slide, which in turn regulate the incoming traffic of various fuels. So again, just to enhance the concept, glucose, fatty acids, or branched these amino acids, they all enter the TCA cycle through production of acetyl coenzyme A. So once there is chronic overnutrition, there are substrates entering through all pathways, and this leads to increased production of acetyl coenzyme A, all of which now cannot enter the TCA cycle for production of NADH. So acetyl coenzyme A enters the alternate pathways, leading to production of the free radicals and causing damage. At the same time, more NADH is being produced that can be utilized by the mitochondria. So NADH also leads to increased production of free radicals and damage. So this is the electron transport chain in mitochondria, which shows that once there is increased production of NADH, it donates electrons to the electron transport complex 1, which leads to increased transfer happening across the electron transport chain, leading to a grid block at the level of ETC3. As a result, there is a backup of electrons on coenzyme QA, which donates electron to the molecular oxygen, leading to production of the superoxide radicals. And studies have clearly shown that there is an increased mitochondrial electrochemical potential if it is exposed to the hyperglycemia. So the current view, developing current view is the transitions between the highly insulin and highly insulin sensitive and resistant states appear to operate as a continuum. And this is a function of demand and supply of ATP. If you have more fuel entering the mitochondria, there is a grid block leading to development of insulin resistance. And this possibly is a mechanism to decrease the uptake of glucose or nutrients into mitochondria. Now, how does this inflexibility lead to beta cell dysfunction? So, in the causing of beta cell dysfunction, there is an important role of FOXO, which is a family of insulin responsive transcription factors and play an important role in mediating the insulin actions by regulating gene expression and downstream effects. Main function of FOXO is to enable metabolic flexibility. It has other function. It integrates energy intake and energy expenditure at the level of CNS, regulates hepatic glucose and lipid production, regulates free fatty acid turnover at the level of adipocytes, and maintains normal endothelial function. In addition, FOXO also carries out very distinct function of maintaining a normal tissue differentiation and maintaining the lineage stability. That means the beta cell will function as beta cell and alpha cell will keep functioning as alpha cell. So once there is derangement of FOXO, these lineages will also change and there can be dedifferentiation of different cells. So what happens is in the post-absorptive state, the FOXO lies in the nucleus and regulates gene expression. Once there is increased supply of calories, there is a phosphorylation media of FOXO and it gets excluded from the nucleus and lies quietly in the cytoplasm. But once there is need for increased insulin, that means once there is chronic overnutrition, there is increased supply for insulin, FOXO again migrates to nucleus and enforces the expression of MODY associated genes like HNF alpha, F4 or F1, and also genes like PDX1, which are important for maintaining the beta cell lineage stability. And this results in improvement of the insulin secretion and more utilization of glucose in an attempt to overcome the degree of insulin resistance. But if the chronic overnutrition is going on for a long duration of time, this FOXO gets exhausted and it stops functioning. As a result, the expression of MODY related genes also decreases and there is increased expression of PPAR alpha, leading to increased utilization of free fatty acids as and increased beta oxidation at the level of mitochondria. There is also increased PPAR gamma, which is perceived or interpreted as an attempt by beta cell to divert carbon molecules entering the mitochondria to the fat cells so that there is decreased damage to mitochondria. So in nutshell, in a healthy cell, the FOXO is intact, functions normally. Once there is metabolic inflexibility, once there is increased nutrient supply, there is increased expression of increased activity of FOXO at nuclear level, leading to on one side expression of genes which are involved in development of diabetes, and on the other side also expression of genes which maintain the beta cell lineage stability. But in due course, if the chronic overnutrition doesn't stop, the FOXO gets exhausted. As a result, there is increased insulin resistance and there is expression of genes which are more involved for dedifferentiation or development of features of progenitor cells at the level of beta cells, and there is decreased expression of genes like PDX1 which are important for maintaining lineage stability. So as a result, the beta cells start losing their normal character. They start dedifferentiating or transdifferentiating towards alpha cell features and ultimately towards null cells. So this leads to beta cell dysfunction. Now, how does metabolic inflexibility lead to the damage to or the target organ damage? And we know these are the pathways of which mediate the chronic complications. The final pathway is the development of oxidative stress, and I have shown you that once there is metabolic inflexibility, there is increased production of free radicals, and this is the unifying pathway. So once there is hyperglycemia, it leads to increased production of free radicals, which damages the DNA at the nuclear level, and this activates enzyme called PARP, which decreases the activity of GAP dehydrogenase enzyme. Now, GAP dehydrogenase enzyme is the rate limiting enzyme for glycolytic pathway. Once there is decreased activity of GAP dehydrogenase, there is increased accumulation of intermediates of glycolytic pathway, which enter the alternate pathways of metabolism, leading to increased production of damaging substances like activation of PKC and production of AGEs, leading to the target organ damage. So in nutshell, overloaded free fatty acids and dysglycemia lead to damaging actions to mitochondria, leading to mitochondrial dysfunction. These damaging pathways proposed are the mutations, the mitochondrial biogenesis is decreased, and there is aging of mitochondria, and this all results in increased production of free radicals and damage development of diabetes and complications. So there is undeniable link between insulin resistance, type 2 diabetes on one hand, and mitochondrial dysfunction on the other hand. Now, can we correct this mitochondrial inflexibility? So since the mitochondrial dysfunction is present in different tissues and contributes to diabetes, pathogenesis, and complications in a number of ways, the therapeutic intervention which targets mitochondria will actually be a very interesting option for managing diabetes and its complications. That's where the concept of mitochondrial modulators is emerging. So mitochondrial modulators are drugs that benefit patients by novel mechanisms that would make the system, tissue, or organ function more efficiently by normalizing what is called metabolic flexibility. We know that as cellular energy hubs, mitochondria allow metabolic switching between normal, different fuels, and this is the normal metabolism. Mitochondrial modulation of glucose and lipid substrate improves insulin sensitivity, insulin resistance in pancreas, liver, and skeletal muscle. And consequently, mitochondria are being identified as the key players in development of diabetes. And if we intervene and improve the mitochondrial flexibility, normalize mitochondrial function, then possibly we will be able to address multiple things. We also know that free fatty acids, are not very efficient fuels, and fatty acid oxidation requires more oxygen per molecule for production of molecule of ATP. So if we have agents which increase, glucose oxidative phosphorylation, or decrease beta oxidation of lipids, or increase the efficiency of fatty acid metabolism, this can lead to improved mitochondrial function. This is also being considered. So this is like using two different fuels in a hybrid car. You are using one fuel for the rapid power, which is like glucose, and there is another fuel which is improving the efficiency of the whole machine, which is coming from the glucose sparing efficiency, coming from the fat metabolism. Now, if to run the car, you need the actually very right mix of these two fuels, and the engine has to be flexible in using the fuel so that as to maintain efficiency. So once there is loss of this flexibility, this leads to the breakdown of the whole system. Now, how does mitochondrial dysfunction happen? There can be changes in the mitochondrial DNA, and there are studies which have shown that there are mutations at DNA level that cause mitochondrial dysfunction. There can be swelling of mitochondria because of intracellular accumulation of free fatty acids, diacylglycerol, long chain fatty acids, and free radicals. And this, they can lead to mitochondrial swelling. There can be disruption of the electron transfer along the electron transport chain and leading to increased production of free radicals and gridlock, decreasing the ATP production. We have studies in new detected diabetes where it is shown that if you compare the individuals with normal body mass index with the individuals who have increased body mass index, there is increased demethylation of the mitochondrial proteins, leading to mitochondrial damage. Now, how do we improve the mitochondrial function? There are a number of mechanisms which are being considered, and there are a number of molecular pathways which are being considered to improve the mitochondrial function. And some of these are the NAD boosting molecules, the mitochondrial membrane property modulators, stacks or certain one activating compounds, OXPHOS or oxidative phosphorylation modulators, AMP kinase activators, PPAR gamma agonists, antioxidants, mitochondrial pyruvate carriers, and so on. And the target is to normalize mitochondrial function to make it more efficient. So what mitochondrial modulators will do is they correct mitochondrial metabolic function, directly correcting metabolic effects in liver, pancreas, and skeletal muscle to prevent oxidative stress and insulin resistance, and directly improve energy efficiency and expenditure to prevent or control cardiovascular risk. So coming back to the concept of dysglycemia based chronic disease model and metabolic flexibility. So the emerging understanding is that genes, epigenetic factors, environmental and lifestyle, they all interact in a very complex way, leading to development of metabolic dysfunction. And this is also, further enhanced by a predisposition for or intrinsic susceptibility to develop this dysfunction and the chronic nutrient excess. Once there is metabolic inflexibility, there is increased production of free radicals, which on one side leads to development of insulin resistance and beta cell dysfunction. On the other side, leads to development of chronic complications. And possibly with the development of mitochondrial modulators, we will be able to normalize this metabolic or mitochondrial inflexibility, normalize the mitochondrial dysfunction, and improve the whole outcome. So to sum up my presentation, metabolic flexibility is the mitochondrial ability to efficiently switch between glucose and lipid metabolism. FOXO1 plays a very crucial role in maintaining the metabolic flexibility and also maintaining the lineage stability of beta cells. Caloric excess and resulting metabolic inflexibility plays important role in development of insulin resistance, beta cell dysfunction, as well as complications. And correcting mitochondrial dysfunction and restoration of metabolic flexibility is emerging as a promising approach for management of dysglycemia-based chronic diseases and prevention of diabetes complications. So with this, I come to end of my presentation. I hope I have been able to finish in
Yes.
time. Just
Thank
in
you.
time.
Yeah, yes, absolutely. Thank you so very much for making such a difficult topic seem so very simple. I just had one question. Do you see mitochondrial modulators, if they ever come in, do you see them emerging as therapy for NAFLD, number one? And secondly, do you see that they will reduce the rate of beta cell apoptosis?
So very important. See, one is if they are coming, yes, the mitochondrial modulators are very much on the way, and that
Yes.
is why the discussions have started.
Yes,
Otherwise,
yes.
nobody would bother to discuss all
This
these
I
things.
know, I know.
Second thing is the answer is yes for everything that you have asked.
Okay.
They are going to improve the metabolism of both free fatty acids and glucose in a way that it becomes more efficient. So there is going to be a decrease, ectopic lipid accumulation, which will help in reducing the NFLD. And of course, if you are able to maintain normal FOXO activity and normal beta cell lineage, then you will maintain the normoglycemia. And if you remember the presentation even from Roy Taylor, the latest presentation he made at ADA, he showed that if you are trying to reverse diabetes, you have to intervene early. What happens is, as the disease progresses, the FOXO gets exhausted. So you have activation of genes which lead to transdifferentiation of beta cells to alpha cells under the influence of ARX and decrease activity of PDX1. And if you allow this to continue for some time, there is further dedifferentiation moving on to the null cell level. So once the beta cell becomes a null cell, you can't make it shift back to beta cell. And so if you give a longer duration of disease, then the chances of remission are less. But if you intervene early, maybe even at the level of transdifferentiation to beta cell, you are able to revert this back.
Right.
So all these are very interesting concepts. So let us see how much will happen in our lifetime. But there will be exciting things happening.
Right. Yes, very, very nice. So thank you so much. Yeah, Dr. Makkar. And the drug reviews and therapeutic session will again resume in the afternoon at 2:15 p.m. And until then, I request everyone to log into the exciting EBM masterclass sessions going on in the Neeraj Chopra Hall. They've just started in the Neeraj Chopra Hall, and the first one is on diabetic kidney disease, the evidence-based medicine masterclass. So see you all in the other hall. Thank you very much.
Thank you very much.
और स्पीकर अपने को कहाँ से लिया है?
उससे आउटपुट दिया।
इससे ही ना?
हाँ,
कोडेक से ही ना?
कोडेक से
स्पीकर पे आउटपुट दिया। ठीक है? रवि मैं यहाँ से बोलूंगा वहाँ पे देखो मोबाइल पे लॉगिन है नहीं लॉगिन करके बाहर वीडियो ऐसा जा रहा है मीराबाई हॉल था मीराबाई अनम्यूट करके क्या हाँ पहले बोलेगा ना मैं करके और वो ये जूम कॉल बंद कर दे
Good afternoon, Dr. Lessig. Are you there? Good afternoon to you, Dr. Lessig. Hi,
Good
Dr. Lessig.
afternoon.
Good afternoon to you. Welcome to the meeting.
Yes, hello.
Hi.
Yeah. Can you see me
I can see you. Yes.
or hear me?
I can hear you very well. Problem. So thank you for accepting our invitation to be at the meeting.
No, it's always an honor. It was, although very short notice, but
Yes, I do
the
realize
topic
that.
was the one I could have it.
Thank you so much.
So we start in like 20 minutes, I
Yes.
understand?
Yes, we start in about 20 minutes. You're absolutely right. You want to try
Okay.
sharing your screen or something like that? You want to try sharing your slides and see?
Yes. Yes, sure.
Yeah. Can Parmeshwar, can he just try sharing his screen?
Yes, sir can share.
Yeah. You can try sharing your screen and see whether you can get your slides on.
Okay. Can you
Yeah, you'll
see
have to
it?
make it full screen. It's not full screen. Yes. Perfect. Perfect. Excellent. Absolutely perfect.
Okay. So you see my slides changing.
Absolutely. No problem. Thank you for sending the slides ahead also,
Okay.
just in case there's a problem.
Yeah, just in case. Just in case.
Absolutely. Yes, yes, yes. Thank you so much.
Okay, so I'm ready. So I understand someone will introduce my talk and then I can start.
I will introduce your talk, sir. I will
Oh.
introduce it.
Okay, great. Are there any questions and answers at the end
Yes.
of the session?
Yes, we'll take a Q&A
Okay.
at the end of the session.
Okay. Okay, great. So I'm ready, waiting whenever you call me.
I will. So you'll have to stop sharing so that we can put your introduction slide up.
Okay.
Perfect. Parmesh, can you put sir's introduction slide up just so that we'll be able to start on time?
We'll do that.
This must be early morning for you, sir, Dr. Lessig?
No, it's it's 10:30. So it's
Yes, okay.
very
Your
much
net
okay.
connection is a bit slow, I think, because you're freezing and coming.
I'll try to improve it.
Maybe. फिर 1 मिनट नीता को बुलाना or any one of them if they
Internet, which might help.
Yeah, because you were freeze, your relay was freezing. So I thought maybe you may have a problem with the net connectivity.
Yeah.
It's the CET time, right? It's CET time, right? It's CET time, right?
Okay, that should be better now.
Yes, it's coming across fine now.
Because it's a much faster device.
Okay.
I have like 40 megabytes per second, so that should be okay now.
Perfect. Perfect. I think this is great.
Hmm. Okay. So in the program, there are 4 talks and then Q&A, yes?
Yeah, but we could
Or will it be-
we can take your Q&A after the lecture itself. So, we could complete the Q&A after your talk. You've got 30 minutes of talk. You could probably spare out 2 minutes or 2 or 3 minutes, depending on, of
Okay,
course, how much time
okay.
you take on your talk, and we could have the Q&A immediately after your talk.
Okay, okay.
Have you been to India, sir?
Oh, I've been quite a few times. That's why Banshi invited me.
Oh, okay.
We know each other pretty well, and I've been to your RSSDI meeting, the last one before the pandemics.
Okay.
I've been involved in postgraduate education activities run by the EASD.
All right.
And we organize number of meetings in India,
Okay.
either separately, I mean, EASD having their conference, or with collaboration with companies like Cipla, USV, Sun Pharma. First time I ever came was over 10 years ago, and it was with Sun Pharma. I think
All
it
right.
was 2008, 8 or 7. So yeah, we had a lot of collaboration. So I've been to many of your cities, from Chandigarh to Chennai,
Oh, wow.
from Jaipur to Ahmedabad. So it's
You've seen practically the length and breadth of India, that means.
yeah, and I know quite a few colleagues as well. And as Banshi keeps getting international speakers, he usually is kind enough not to forget about me, and sometimes he arranges me to have a talk. So yeah, and I absolutely enjoy it because you have a much broader view at diabetes or at metabolism. I mean, you concentrate on evidence and studies, but you also have your tradition, and you also have your views on all the things about lifestyle management, you know, not necessarily the things not related to pharmacotherapy. Sanjay Kalra is another good friend of mine, for example. We lectured together in Iran, I think. Yeah, we met. No, in Pakistan. We were in Pakistan.
Oh, wow.
For a lecture tour a few years ago. And then we had a couple of papers together. So yeah, India is absolutely not a foreign place.
In fact, Sanjay is speaking in the other hall right now. So he's actually giving a lecture.
I've just been listening to his session on aging. Yes. He has a very philosophical approach, sometimes pretty surprising. To diabetes, quite original, but it's thought provoking, yes, and he puts a lot of passion into what he does and what he speaks about.
Oh yes, he's totally passionate about it. So it's so nice to see.
So I very much enjoy it as well. And it's great that you run, I understand that you run plenty of programs like that in India.
Yes.
And you keep in touch with outside world, of course. So it's great that the things are going on despite the pandemics.
Yes, I mean, we make it a point. I'm also the national secretary of the RSSDI. So Bansi is the president and I'm the secretary of the RSSDI. And we work together as a team. And this is a meeting, the IDEC meeting we host every year. This is the 5th year that we're hosting. And we haven't missed out. And we've had a number of good speakers like you who have been part of this meeting. So, you know, we enjoy listening to you and we get a perspective of what's happening outside the country. And it's so important that, you know, we learn to interact with each other because that helps us to see where we should improve ourselves too.
Yeah, absolutely. And it's as India is still, unfortunately, one of 2 diabetes capitals in the world. Gulf countries, yes, Arab countries being the other capital. Well, the problem is great, and it will be rising. We can see it that because of pandemic, we have many more cases of newly diagnosed type 2 diabetes in young people who simply put on weight a lot while doing, you know, home office work. They work from the home, close to the fridge. Not much exercise. So we have now patients in their 30s, late 20s, who put on 10, 15 kilos of weight over the course of a year and a half. And now they become as type 2 diabetic patients.
Absolutely.
So and the other thing was that all our hospital system, the Ministry of Health decided to be very, how to say it, COVID-centric. So if you had COVID, there was no problem for you to get to a hospital, to get a bed, to get a ventilator, oxygen, everything. But if you didn't have COVID, then it was a problem because all GP practices went to online services. So there was delay in diagnosis of cancer, other conditions. So we paid high price, not in people who died because of COVID, but people who died because of late treatment or late diagnosis of other conditions. So COVID is a pretty controversial issue in my country. Now, when we look back at it, on the other hand, I keep saying we've never been trained how to deal with something like this. Yes, we were completely unprepared. So it's always wise. You're always wise afterwards, but when it happens, and we had a horrible peak in cases in October last year, when really, you know, people were dying in ambulances which waited in the queue in front of the hospitals. So
Wow.
this was not heavily publicized, but we saw it. I work in a hospital, so we saw it.
But I believe now, even till date, now Europe still is battling, and the numbers haven't that gone down, and again they're on the rise, and there are a lot of portions of Europe that are still in lockdown. So
We people are afraid, but we not doing that bad with vaccinations. We have about 60% of population vaccinated. Still, me and my colleagues, we are very surprised how many people resist vaccination, saying that it's, you know, Bill Gates putting chips under your skin just to monitor you, you know, all those incredible stupid things. Many people, even well-educated people, are against being vaccinated. So we will pay the price with something we call the fourth wave now, but it will not be that big as it was before, because many, you know, those who died. Those who got through COVID, they are somehow immune. And as I said, 60% are vaccinated. So we are rather looking forward to reopening again, to the conferences, meetings, to normal work. We start students in 3 weeks' time. Academic year starts in October, and we will resume regular student classes, seminars in hospitals. So hopefully soon, maybe next year, if you would like to invite me, I'll be able to come to India and we can
100%.
see in person.
100% we'll want you in India physically, because that's a totally different experience.
Oh
than
yes, oh yes. And the beauty of attending conferences in India is that your colleagues, you're never inhibited from asking questions. So there are always many questions. You know, people standing up and actually giving co-lecture, wanting to ask a question. Yeah, but this is great because you have always. I remember when I had a talk in India and when we finished the session because of time, and then during the break there were people queuing to me to ask a question. Sometimes they just want to show, look, we're also pretty good. We treat these patients, we have these drugs, but that's fine. When you go to countries like China or some parts in Europe, people are very much too shy, you know, to stand up to ask a question. It's sometimes very difficult to stir the discussion. And in India, it's never a problem. So that's very pleasant.
Yeah. I mean, since you're such a good speaker, people will always love to interact with you, and that's the thing. Yeah? People love to ask questions, learn from everybody, and
Yeah, they're very open. They're very open.
they don't hesitate.
Yeah, and the thing which never stops to amaze me is that, you know, we live in different parts of the world, different cultures, different traditions. We eat different food, but the disease itself is absolutely the same. The patients have the same problems, the doctors have the same problems. So that's why we can meet, you know, from two sides of the world and still have plenty in common. That's wonderful. That's wonderful.
Superb, superb. Okay.
Okay, so the
I
moment you
think
tell me to share
yeah.
the slides, I will start sharing.
Surely. So I think I've got the green signal to go ahead and start the lecture. So good afternoon, everybody, and I welcome all of you back to the Mirabai Chanu Hall. We've got a very astute speaker today with us who's going to talk to us about managing dysglycemia-based chronic disease, the serendipitous story of dapagliflozin. It's a pleasure and honor to introduce Professor Lessig, and he's an internal medicine specialist in diabetology, head of the Diabetology and Internal Disease Clinic at the Medical University of Warsaw. He graduated from the Medical Academy, and I'm not very sure how do you pronounce this, in 1994. Perhaps you can help me, Dr. Lessig.
Well, we pronounce it Łódź. It means boat, ship. So that's a funny name, but without all those commas on top, which are typically Polish letters, internationally it's pronounced just LODZ, L-O-D-Z, LODZ.
Ole, lots.
Yeah.
Thank you very much. He completed foreign training and research internships in Oxford, London, and Wakefield, Massachusetts, and Miami. In his clinical practice, he focuses on the diagnosis of carbohydrate tolerance disorders and the treatment of type 1, type 2 diabetes and diabetes accompanying other diseases, as well as chronic complications of diabetes, mainly in the circulatory system, nervous system, eyesight, digestive, and kidneys. He pays special attention to the principles of using oral agents and insulin. So I give the stage to you, Dr. Lessig, for a wonderful lecture that we are waiting to hear, and that's on managing dysglycemia-based chronic disease, the serendipitous story of dapagliflozin. Over to you, sir.
Oh, thank you very much for your extremely kind introduction. It's an honor and a pleasure to be part of any meeting in India, and I've been fortunate enough to be invited a few times to the online meetings I understand you have many of them. This is, however, the first time I'm ever part of any conclave. Conclave in our tradition is the meeting of bishops. This is the moment when bishops meet to elect a new pope, and you have to be not just a bishop, you have to be a cardinal. So this is the first time I'm participating in conclave, and thanks very much for this as well.
Thank you.
So I hope you can start seeing my slides. I put them in presentation mode. I hope you can see them.
Yes, we can. You'll have to just make it full slide.
Okay, thank you. So I was invited to speak briefly on managing dysglycemia-based chronic disease. This is an elegant name which covers diabetes and complications, as I understand it. And using the example of dapagliflozin, I would like to tell you this serendipitous story of this drug. But you can look at it at a broader sense. In a way, it's a good representative of all, with some differences between the drugs, but of all SGLT2 inhibitors group. So it is a serendipitous story, and it is also a story of being humble. This is a story of the power of evidence over presumption, assumptions, intuition, because many things which happen with SGLT2 inhibitors are actually contra-intuitive, and the history of these drugs is not over. We will still learn much more. We will see. Okay, we know that diabetes, and this is the way the British used to describe it, is a vascular disease. Endocrinologists deal with it because insulin is a core drug in diabetes. So insulin is a hormone, and if anything is a hormone, that belongs to endocrinology. But that is slowly and slowly further and further from the truth, because the disease is much more complex, as we know, and the patients do not really suffer from hormonal disorders, they suffer from vascular complications. This is one of the old studies which you can see here, that when diabetes is combined with coronary heart disease, like here, patients with diabetes and myocardial infarctions, they die more often, regardless of the gender, whether they are male or female, and combining, if we compare diabetes and suffering MI, the fate of the patients is also similar. Importantly, we've never had any agents for diabetes until recently, which in a meaningful way affected this fate of the patients determined by vascular complications. We still have powerful agents to lower blood glucose, insulin being number one. And this year we celebrate 100 years of insulin discovery. But this did not affect, has not affected the course of vascular damage in diabetes. And although over the course of years at the turn of the centuries, we were able to see, this is a Swedish example, we were able to see the decline in mortality within the first year after MI. You can see here the 15-year course of follow-up. Still, patients with diabetes, shown here in green, remain at a higher risk of death when they develop MI. So what we achieved in decreasing vascular complications or cardiovascular risk, it was achieved not thanks to diabetes treatment. It was achieved thanks to better hypertension control, better treatment of dyslipidemia, less smoking, better nutrition, things like that, but not so much with diabetes treatment. And it all has changed in recent, not even a decade, in the recent 5-6 years. This serendipitous story started with a series of, let's say, tragedies or some negative events in the history of metabolic pharmacotherapy. If we look back to as early as 1997, there was a drug called dexfenfluramine. I'm not sure if it reached India, but it was popular in Europe. It was produced by Servier, was called isolipan, and it was used in obesity treatment. It was on the market for about 3 years, but then was withdrawn because of evidence that it caused valvular disease in the heart. Then we had one statin, serivastatin, produced by Bayer, which was very powerful. It was it was stronger than even rosuvastatin, but it also caused rhabdomyolysis and disappeared from the market after about 1 year. These all drugs were licensed and put on the market and were used by physicians. Then we had rimonabant, the drug which was used, the trade name was Acomplia, was used by in several European countries for obesity treatment as well. Quite effective, good studies in diabetes. It was pretty quickly put on market, but it caused the exacerbation of depression and most notably led to the increased risk of suicide. And it was withdrawn in 2008. Then we have the history of PPR gamma agonists. Troglitazone, the first one was started to be available in UK, but after it caused fatal liver failure in about 30 patients, it was also quickly withdrawn in 2010. We also, for quite some time, about 8-9 years, we had the availability of sibutramine. The drug was called Meridia, also for obesity treatment. But they were shown that the drug was shown in one study that it increases the risk of cardiovascular death in elderly men. And the final step here was rosiglitazone, which was suspected in 2007 that it might increase the risk of myocardial infarction. This actually has not been confirmed, but the drug was withdrawn in Europe. It's still available in US, and it's called Avandia, as you know. So after this series of blunders, FDA decided, as we know, to issue kind of a guidance telling the industry, okay, if you want to make business in the US, and this is a gold mine for pharmaceutical companies, you can get as much money as you want by selling drugs. Their drugs are expensive, especially insulin, which is quite outrageous for us from European perspective, but it's also due to the characteristics of US insurance policy, health insurance policy, which works there. FDA issued the guidance that you have to check and told to the companies, you have to check whether your new drugs, which you are going to put on the market, are safe in terms of cardiovascular safety. And of course, if FDA tells you jump, you jump. So the companies follow suit, and they follow this guidance. And this is what happened. Many companies, virtually all companies which wanted to come with a new drug for diabetes, they started their cardiovascular safety trial. And 2008 was the moment when guidance was issued, and very quickly, mostly DPP-4 inhibitor companies managed to put up the studies, and they ran the studies like, say, Vortimi, Examine, and TICOS. Those studies were largely negative. I mean, negative. They showed safety, but this is where the serendipity starts here. The expectations were raised so much by the companies before the publications of these studies. You might remember that we all expected that these drugs will show something more. Before the publications of TICOS or Examine, there were meta-analyses showing that DPP-4 inhibitors might decrease cardiovascular risk. These studies are still available. But the study, the TICOS is number one here because it was the largest of longest duration, clearly showed that gliptins, being good drugs for glucose lowering, they do nothing more. And at that moment, I remember the discussion, there was even editorials published in New England Journal of Medicine, that probably FDA got it all wrong. They made companies spend millions of dollars to study the safety of new anti-diabetes agents, and all for nothing. I mean, okay, drugs are safe, but we don't expect drugs to be unsafe at this level of development. They all have the pre-registration studies, first, second, third phase. And this is just making company spend a lot of money in vain, while this money could be allocated to a better research, more innovative, and simply bringing new drugs sooner. And then the autumn of 2015 came, September 2015, EASD annual meeting in Stockholm, where EMPERAG outcome results were published. And all then changed, as we know. But this, I will refer to it in a moment, this already was the moment when we had SGLT2 inhibitors available. I'm using this sculpture of Peeing Boy. This is the symbol of Brussels. Brussels, as you know, is the capital of European Union, and that's an official and elegant way of showing passing waters, and I hope no one is offended. So SGLT2 inhibitors arrived in Europe in the form of dapagliflozin. This was 12th of November of 2012. And as you may realize now quickly, this was like 2 days before World Diabetes Day. And this was done on purpose. European Commission just wanted to, in a way, celebrate World Diabetes Day. And they allowed the first drug from this group in Europe. In US, the first SGLT2 inhibitor was canagliflozin. This was produced by American company, Johnson & Johnson, while dapagliflozin, as we know, is produced by AstraZeneca, a global company, but largely a British, Swedish, British, Scandinavian company. So the drug called Forxiga in pharmacies was put on the market. It is now marketed by AstraZeneca and produced at that time. It was British Myers Squibb. That was the name of the company. And the representative of BMS came to us and was telling us to prescribe dapagliflozin, telling us how it works, how these drugs works, and we know it, of course, that they block the sodium glucose transporter in proximal tubules in the kidney, and thus they stop reabsorption of glucose in the kidneys. But this picture is very much obsolete. We now know that SGLT2s work not just here, or at least they do work here, of course, but the effect of this blockade, inhibition of SGLT2, is going much farther than just stopping reabsorption of glucose. And as you may remember your reactions, we were extremely skeptical. We were just knocking on our heads and saying, it's kind of a stupid idea to make people have glycosuria, while if you're as old as me, I remember times when glucose meters were just entering. It was mid-90s, I was graduating at the time, and many patients controlled their glucose or got the information about glucose diabetes control by taking urine sample to the lab every 2 weeks. This was the tradition, and they measured, and in the lab they measured whether there is glucose in the urine or not. If there was no glucose, of course, the patient heard from the doctor, your diabetes is well controlled. This was the pre-glucose meters era, and it was just 25 years ago. And now we are causing mega glycosuria. And of course, infections must be related to it. So we were really, really skeptical. And this skepticism was well justified. If we look at the literature, this is the description of diabetes from 17th century, from an English book. And it says that you can see here that why the piss of those that are sick of this disease is sweet like honey. And diabetes was called a pissing evil because people with diabetes just pissed a lot. And now we are just causing it. Cannot be reasonable and cannot bring any good. I remember my own impression. And as I said, this was the lesson in being more humble and wait for evidence. November 2012, dapagliflozin arrives in Europe. July 12, there is an editorial in the Lancet telling us that SGLT2 inhibitors treatment is actually turning symptoms into therapy, and we also had to concede with that. So we know about dapagliflozin when it arrived to our pharmacies, that this is a drug which works well in terms of lowering HbA1c. We can see here 2-year follow-up and the long-term efficacy, maintained efficacy in lowering HbA1c, and that it also was effective in weight reduction. The patients lose about 300 calories per day using SGLT2 inhibitors, and this was also maintained for 2 years. And this is all what we expected. We heard from time to time about mycotic infections from our patients, but we were far from being enthusiastic of prescribing these drugs. Even if there were some data showing that if we use dapagliflozin, this is animal data, you may increase the amount of active beta cells. This green dots here, green area, is the area of beta cells. On the left-hand side, you can see an islet of Langerhans before and after dapagliflozin treatment. So these drugs putting away or decreasing the hyperglycemic stress on beta cells somehow help them to be more active, to regenerate. We don't know really what happens, but they definitely may preserve beta cell function. But our attitude until 2015 was similar to this picture, when the lady comes to the doctor and she's saying, look, I feel much better now when I have run out of those pills you gave me at the last visit. So our skepticism was also joined with that sort of reaction from the patients, especially that we were not very much pushing these drugs to the patients. And then, as I said, November 2015, EMPERAG outcome is published, the results of the study is published, and we all know it very well. An immense decrease in cardiovascular death occurring at the very beginning of the prescription of this drug. We now know that one of the main drivers, clinical drivers for this cardiovascular risk reduction is reduction in the risk of hospitalization for heart failure. And it also occurs very early on, which also means it's very clear that it is not related to glucose lowering effect, or very little. It's just impossible that if we lower glucose, we will see any effect in cardiovascular system within weeks. It would have to take months, if not years, to affect cardiovascular system just by lowering glucose, blood glucose levels. We were also surprised 6 months later, in June 2016, when the data from EMPERAG outcome were shown at the American Society of Nephrology meeting, that it also decreases the risk of progression of chronic kidney disease. While we were happy thinking it would be good if drugs like dapagliflozin will not deteriorate kidney function because they may just cause infections. So this was really the lesson of, wow, I mean, everyone was surprised, including the companies. Boehringer Ingelheim producing as empagliflozin did not really expect these results with their study. Very soon after, we had the results for dapagliflozin in a very similar study, this cardiovascular safety series of studies. And the study with dapagliflozin was called DECLARE. It was the third in series with SGLT2 inhibitors. We had EMPA-REG outcome for empagliflozin, CANVAS for canagliflozin, and DECLARE published in November 2018. And this was the study which was different from the others in terms of the number of participants, over 17,000. And these patients were also relatively healthier. There were many patients who just had multiple risk factors who were enrolled into this study, while in EMPA-REG outcome, patients had cardiovascular disease which was already established. So they were more sick patients. In DECLARE study, we had patients more representative to our daily practice. The study was a global one, and you can see here that there were patients recruited both in Poland and also in India. So a pretty good representative study for the patients from all over the world. The mean age of patients was 64. They were not ideally controlled, 8.3. From your region, about 13% of patients came from Asia Pacific. A few patients with heart failure, though, only 10%, as you can see here, and minority had established cardiovascular disease. So this is the difference with EMPA-REG outcome. The drug, although it was not the intention of the study, lowered HbA1c by about 0.4%, lowered body weight, and also lowered blood pressure, systolic blood pressure by close to 3 millimeters of mercury. And the discussion of these effects, how much they contribute to the decrease in cardiovascular risk, is actually still ongoing. It's very difficult to dissect it. The primary endpoints were a little bit disappointing, I might say, because you could see that cardiovascular risk combined with heart failure, with a risk of hospitalization of heart failure, this is the left-hand figure, this was reduced in a statistically significant manner by about 17%. So this is an elegant reduction. But if you look at MACE, those major cardiovascular events, this is the reduction here, was not statistically significant. The explanation and thinking that this was a disappointment is, however, not justified. This was simply a little bit healthier, not even a little bit, a healthier population, and it would, to see the difference in reduction in cardiovascular death, for example, as a study would have to last a few years longer. But cardiovascular death and risk for hospitalization for heart failure, which was predefined endpoint, was a success here. The similar successes was in decreasing renal risk by 24%, no effect on all-cause mortality. And because this was compared to EMPA-REG outcome, as I said, this was kind of a disappointing, but it's quite easy to be explained. Also, if we think if timing is everything, as we say, so if DECLARE was presented before EMPA-REG outcome, this would be great news, and everybody would be cheering the study results. This was the third study, and the expectations were high, but it simply could not have been fulfilled with this study design. DECLARE was put in front of or put in comparison with CANVAS and EMPA-REG outcome studies, and still, even if not statistically significant, the tendency to reduce cardiovascular risk was clear. This is the upper part of this figure. But if we look at this combined endpoint of cardiovascular death and hospitalization for heart failure, the risk is reduced quite similarly in all these three studies. The greatest in EMPA-REG outcome, the lowest in DECLARE, but still a very similar effect on cardiovascular risk. So the companies, when they already in 2018, 2017, or immediately after EMPA-REG outcome was shown, the results were shown, it was clear that heart failure is something the companies should concentrate on. And here, AstraZeneca was the quickest. They produced dapagliflozin heart failure study, the study which was done in patients with heart failure and with or without diabetes. As we know, patients had ejection fraction had to have below 40%, and clearly the effect was evident. The reduction of 26% of cardiovascular death or worsening heart failure, regardless of diabetes status. And also very importantly, dapagliflozin shown here in the study, it wasn't the aim of the study, but it was clearly shown that using dapagliflozin delays onset of type 2 diabetes. So we might also think that these drugs maybe at some moment will be also licensed for diabetes prevention. They also decrease the need for insulin introduction in type 2 diabetes. And the third in series was the study with assessing the effect on chronic kidney disease, as we know, because this effect, completely unexpected, was also clear with SGLT2 inhibitors. This was the study published as a third in the series of dapagliflozin. And this is an impressive result, 40% reduction of progression, of the risk of progression of CKD. Also, regardless, if you look here on the right, regardless whether the patients had diabetes at baseline or did not have our favorite disease. In this renal population, in DAPA-CKD, dapagliflozin was also effective in decreasing cardiovascular death, all-cause mortality by not little amount. This is over 30% risk reduction. However, in this population, it doesn't start that quickly. Your patients have to be treated for a few months to see the result. So we suddenly, and I mean suddenly, how we understand diabetes and in our diabetes temper. So it's not over a week, but over 3-4 years, we saw the immense effect of SGLT2 inhibitors on the vascular risk, on the history of vascular complications development, with a relatively good safety profile. If we look at safety results in these 3 studies here, really the differences with placebo are none, with one exception. Genital infections are a little bit more often than with placebo, but in clinical practice, it really affects few patients. Patients has to be warned that something like that may occur, and the hygiene regimen, if increased, it can only decrease the risk of genital infections, but they do occur, and we all know it. So this is the summary of this dapagliflozin study results. We see absolutely positive result in glucose control, in risk reduction of cardiovascular and microvascular events. Nephropathy is a marker of microvascular complications. We've never had drugs like that before. And this, of course, affected the guidelines. These are the last my few slides. In 2012, and this is also an irony of timing, ADA and the ASD published their recommendations, and you will not see in this colorful figure SGLT2 inhibitors. This was published in mid-2012, and in November 2012, dapagliflozin started to be available. 3 years later, in 2015, another edition of these recommendations, we do see SGLT2 inhibitors here, but they are just like any other anti-diabetes agent after the DPP-4 inhibitor as the last oral agent mentioned here. Sulfonylurea being number 1 as the drugs with the longest history here. But it all changed in 2018. This was the first version published after 2015 EMPEROR outcome results. Also already the results of CANVAS and DECLARE, they were known. And here, if you count how many SGLT2 inhibitors are mentioned, they are as frequently mentioned as GLP-1 receptor agonists, around 14 times. And they are recommended to be used independently of baseline HbA1c if patients are at high risk of vascular complications. So we are already utilizing the mechanisms of SGLT2 inhibition quite widely. We use it to control glucose. We use it to a little bit to control body weight. We help patients lose some body weight. We, of course, utilize it in improving the function of cardiovascular system and kidneys. One thing which is still left and which is ahead of us, and this will be the next part of dapagliflozin's story, is its use in liver steatosis, because dapagliflozin, like other SGLT2 inhibitors, has also very good results in improving NASH or NAFLD. So this will be the next step here. Thank you very much for your attention. I tried to cover this longer and fascinating story as quickly and as comprehensively as I could. Thank you.
Thank you very much, Dr. Lessig, for this wonderful presentation. I'm sure it was a pleasure to hear you speak on this topic. We have time for just quick 1 or 2 questions. I'll be happy to put it to Dr. Lessig. Let me start by asking a question. I mean, when the SGLT2 inhibitors were actually came into force and we wanted, when it came up for practice, it was primarily only an oral anti-hyperglycemic agent. Over time, it has transcended and it's gone, across boundaries into the realms of cardiologists and nephrologists. And now, for somewhere, we have also decided that, they are also useful for patients without diabetes. Now, how did the initial ethical committees decide that they could include patients who didn't have diabetes for this, for the molecule? So how did the ethics committee could approve this?
This is again a sort of serendipity, because with unexpected results of EMPEREG outcome, where the main mechanisms, the main driver for decrease in cardiovascular risk, and remember that in EMPEREG outcome, there were patients, half of them already had myocardial infarction, 3/4 had coronary heart disease. So many of them had, in fact, systolic heart failure. And when they realized that this drug somehow, and independent of glucose lowering, because it happened very quickly, must affect heart, then the ethics committee agreed it would be wise to test the study in patients with heart failure and not necessarily with diabetes. This was also possible for one reason, that this drug does not cause hypoglycemia, because if they were causing hypoglycemia, we wouldn't be able to use it outside diabetes setting. It's the same with GLP-1 receptor agonists. And of course, that's proven to be quite successful, and cardiologists are now moving to the direction that this will be the leading drug in treating heart failure. So this is really an amazing story, but I don't think it was very difficult for ethical committees to accept it. The evidence from EMPEREG was really compelling, and this was a logical step to test it in this group. The next step, for example, would be to test SGLT2 inhibitors in pre-diabetes or in obesity to see, are these drugs effective in decreasing the risk of diabetes, especially when any generic forms will be available and the cost of the drug will come down.
Are there any other questions that I can't see any in the... Krishna, would you have any, or Sunil, would you like to ask any questions to Dr. Lessig?
I exhausted the topic and I exhausted the audience.
No, you covered it very well.
Thank you very much.
Thank you. Thank you so much, Dr. Lessig. It was a pleasure to hear you speak. It was a wonderful talk, and we hope to have you physically in India next year. I'm sure things will be better, and we'll have the pleasure to have you with us.
Thank you.
Thank you so much. Our next speaker for the day is Dr. Krishna Seshadri. He's already been introduced earlier, so I'm going to ask him straight to get on to the talk, and he's going to speak to us about choosing the right patients for SGLT2 inhibitors. So the stage is yours, Krishna. Is this your screen or our screen?
It's my screen. So.
Okay, yeah.
Thank you, Sanjay. Thanks for having me in this program. It's not as good as being in Pune, but I'll take it as it comes. And thanks for the hospitality that you extend each year. if you notice in most conferences now, and you know, even in ours today, SGLTs have taken most conferences by storm. But what it sort of leaves behind for many of us who are in primary care is, okay, all this information is fine, but who do I give these drugs to? Who do I not? And what do I take? So what I've done is I've distilled down a workshop that I've done, that I do for practitioners, and you know, retained its essence and made it exceptionally simple to think about it. And what more can you have to make things simple than have patience? So these are my conflicts of interest. I have speaking on an area for many
You haven't
SGLT.
shared the presentation.
It is.
No, you've got a word sheet on.
Oh, I'm so sorry.
Is the Octet Endo meeting worksheet.
What worksheet is there?
Octet Endo meeting at Chennai.
Let me see. Okay,
Please
so
stop sharing and
I'm
then
so sorry.
again share.
I'll share it again. Just a minute.
Yeah.
Now?
It's just
Okay, so great. So these are my conflicts of interest. I have speaking honoraria for most SGLT2 talks that I give. So let's look at this patient, 54-year-old woman, type 2 diabetes, 7 years on multiple medications. Height is 161, weight is 82 kilograms. eGFR is 92 and urine albumin creatinine ratio is 22, A1C is 8. So let's quickly go through the questions if we will. What is the target A1C? What are the drugs that will bring you close to the target? And are there any other additional benefits of the drug in this situation? And most of you who know this well know that the A1C for this patient who's had diabetes for a while, a good way is look at 7%. Is an SGLT2 inhibitor useful in this situation? When compared to a DPP4 inhibitors, what are these better choices? We know that SGLT2 inhibitors have been around for around 5 years. There's a large body of evidence. You've been hearing it throughout this meeting, in many other meetings that you go through. We know it works by preventing glucose reabsorption, increasing the filtration of glucose. One of the drugs that we use is dapagliflozin. Most of the stuff that we talk about in terms of DPP4 inhibitors can be classified as a class A effect. When compared to a DPP4 inhibitor, which is something that all of us keep wondering what to use, we know that there are 4 important benefits for SGLT2 inhibitors. One is they cause weight loss. One is the second, they have benefit in ASCVD. They have benefit in preventing established ASCVD, I'm sorry. They have benefit in preventing heart failure. And now we have some data about HFpEF also. And clearly they have benefit in terms of PKD. The DPP4 inhibitors are wonderful diabetic lowering agents, but these 4 effects are better with a SGLT2 inhibitor. We have data on the use of SGLT2 inhibitors as monotherapy with metformin and as combinations. In each of these, the A1C reductions are consistent between 0.6 and 1. And in most of these, there is also additional benefit in terms of around 1.5 to 2 kgs, especially with dapagliflozin in this particular study. So clearly, we know that it can get you closer to the A1C that you require, right? And it will also cause some weight gain. But should you do anything else for this patient? What additional history should you obtain? Any other testing that is warranted, and how do you educate this patient? Most importantly, make sure that you don't have any other problems, especially with the urinary tract infection. If somebody has urinary tract infections and recurrent urinary tract infections, recurrent vulvovaginal candidiasis, and these are not patients that you should be using this drug for. The most important test that I would get in any patient is an eGFR. Remember that as the eGFR comes down, the glucose lowering ability of the SGLT2 inhibitor comes down. However, its benefit increases simply because as an off-target effect, it works in DKD, and we can talk about it. The side effects that I educate the patient is one is non-hyperglycemic ketosis that patients can develop in insulin deficient situations. And of course, urinary tract infections and genital mycotic infections. Also tell them that if they test their urine for glucose, it will be positive and not to get worried about it, and would not advise it to women who are planning to or are pregnant. How do you prevent genital infections? Genital hygiene, adequate hydration, and of course, talking to a doctor when this happens. Indeed, in this particular patient, this happens. What would you do? Would you stop the drug? Can you treat through the infection? What if there's a recurrence? I think most of us now agree that you can actually treat through the infection. For simply vulvovaginal candidiasis, I use 3 to 5 days of a vaginal pessary. If there is recurrent infection, I would stop the drug and then maybe even use oral fluconazole. In many patients, after some time, I actually try re-attempting introduction of the drug, especially if it's important, and I'm using it in heart failure, renal disease, or in patients with, established coronary artery disease. So in this patient was treated through the infection, the itching settled, and you can notice that her BMI has come down, her sugars are fairly close to normal. And remember, there was glucosuria, and all you have to tell this patient is that this is how the drug works. Do not use, and you really don't have to get urine glucoses regularly. Tell your lab to stop measuring it, and this way you can get this headache off your head. She's fine, she's asymptomatic, but the weight loss is not continuing. And also there's a mild drop in eGFR. What should you do? One, remember that the weight loss does not continue after some time and plateaus simply because the body actually slows down its metabolism. There is also an important part to it, and that there is an increase in intake. So one of the things that you should talk to patients about is that they should continue to be on a diet. And if they don't continue to be on a diet and they loosen up, they will gain weight after some time. This is one bit. So there is an adaptive increase in energy intake. This was work that was done by Ferranini et al. The second thing to tell patients, of course, is to also use other drugs in combination. And we won't do it today, but an SGLT2 inhibitor plus a GLP-1 RA is an amazingly potent combination. Also important to understand and tell patients that the initial dip in the EGR is very important because it tells you that over a period of time, how this drug is going to work and help your kidney. One of the things that the simple way to look at this is the serum creatinine up by more than 30%. If it is, check for volume status, depletion, and acidosis, and consider stopping the drug. On the other hand, if the increase is less than 30%, continue the treatment with an SGLT2 inhibitor. This is a treatment effect and a very desirable effect at that. So we sort of understood what to do with patients who are to add on to drugs. What about a patient who has established cardiovascular disease? Here is someone who's 55 years old, type 2 diabetes for 10 years, on multiple medications, eGFR is 60, albumin creatinine ratio is 70. You notice that, I'm making a specific mention of eGFR. The reason is for us to understand that this is a calculation that we must do for all particular patients. You know that this patient will do well with an A1C of 7.5, but what are the priorities for this patient? Here an SGLT2 has both indirect effects in improving glycemic control, reduce insulin levels, a whole bunch, but there are some direct effects on this patient in the kidney as well. So in patients with reduced eGFR and albuminuria, are there benefits of adding the SGLT2 inhibitor? Is there evidence to support it? Absolutely. And this is where the DAPA-CKD data comes in. You will notice that the hazard ratio in this particular study was 0.61 with a 95% confidence interval. And you can see again the separation of curves by around 8 weeks. It's a very, very, very substantial thing. And the primary outcome in this particular study, which was a combination of endpoint, which was a sustained decline of eGFR of 50%, end-stage kidney disease, and death, renal and CV diseases, you will realize that irrespective of the patient being diabetic or non-diabetic, in the presence of proteinuria, there was clearly benefit for the patient. And that is why today, if somebody has CKD and albuminuria, the drug of choice is an SGLT2 inhibitor with evidence for reducing CKD progression. Right. The question, of course, that many of us ask is if a DPP4 inhibitors combined with SGLT2 inhibitors, are there added benefit? Because this is one of the most common combinations that we use. Theoretically, there seems to be a lot of benefit, especially because at least at the albuminuria, there is some benefit with the DPP4. But overall, no one has demonstrated in a meta-analysis that the combination has added benefits. But at least we know that there is no harm. The SGLT2 inhibitors increase glucagon, the DPP4s decrease it. But what is important to understand is they work fairly well together, but not necessarily additive. They are quite complementary. That brings us to our next patient who was admitted with a STEMI and a PCI. 3 years later, 3 weeks later, he comes to you, no history of diabetes, glucose is around 160 to 180. He's on cardiac medications and statin. What should you do for this patient? This patient, of course, the A1C is less than 7.5, is an OHA indicated. What should you do? In this particular patient, irrespective of whether this patient requires another diabetes medicine or not, I would add an GLP-1RA with a proven CVD benefit or an SGLT2 inhibitor with proven CVD benefit. His eGFR is around 90, so it's a flip which of these drugs that you want to use. But clearly, an SGLT2 inhibitor is an oral drug and work. That brings up the question: should metformin always be the starting drug? And can a patient be started on SGLT2 inhibitor monotherapy? And can we use dapagliflozin in this context? So the ESC's algorithm now tells you that in drug-naive patients who are ACVD high or very high, start an SGLT2 inhibitor or a GLP-1RA monotherapy. And this, while this is path-breaking, it's not unusual. And also there are some studies that tell you that metformin actually reduces the effectiveness in an SGLT2 inhibitor in this situation. Whether that is something to be believed or not, I think there is a lot of data to start thinking about SGLT2 inhibitor monotherapy and not necessarily think of metformin as a Ganesha of type 2 diabetes. This is a sub-analysis of the particular TIMI trial that told you that in patients with previous MI, there is a reduction, relative risk reduction by around 60% in the MACE, and a greater benefit for MACE within 2 years after the last event. And again, many of us believe that this is a class effect and can be used. This patient is a 65-year-old under your care for diabetes, has diabetes and hypertension for 15 years, complaining of shortness of breath with some activity, third heart sound and mild pedal edema, has an ejection fraction that's around 40%. So he's on saxagliptin, metformin, gliclazide, eGFR is 70, UACR is 35. So even without the heart failure, he already has some indications to start an SGLT2 inhibitor. But what are the things that you would do? Clearly, many of us will tell you, stop the saxagliptin. But what about the other drugs? So the SAVOR-TIMI clearly showed that in patients on saxagliptin, there was a slight increase in hospitalization for heart failure. And the FDA's advisory, not a black box warning, but an advisory about heart failure for all of these things, right? So we know that there are drugs today. The drugs for heart failure include a beta blocker, ARNI, and an MRA. Other drugs, which I won't go into, I'm not an expert on this, but these are the 4 cornerstones. This is the DAPA-CKD trial. People have talked to it again and again. I'm just going to tell you that the inclusion was class 2 to class 4, left ventricular ejection fraction of 40%, NT-proBNP of greater than 600. There was a reduction in hospitalization, irrespective of diabetes. There was a reduction in all-cause death, consistent across all the subgroups, all the renal function. So he's a diabetic for 50. So let's change this slightly. So clearly we know that in patient with compromised heart failure, HFrEF, the reduced ejection fraction, there is benefit when using an SGLT2 inhibitor. What about someone whose 2D echo is 56% and LVH? This is someone who has what we call HFF, right? There is no reduction in ejection fraction. And when I first gave this talk, I had written underneath this, there is no evidence. But now we know with the Emperor Preserved study that there is benefit, that the hazard ratio, this was empagliflozin, a hazard ratio 0.73, confidence interval of 0.61 to 0.8. Just to let you know that the benefit was more with the ejection fraction between 40 and 50 than between 50 and 60. And importantly, other than the primary composite outcome and the hospitalization for heart failure, none of the others were very significant. In fact, there was a divergence in between the HFrEF in the Emperor Reduced and the Emperor Preserved in terms of the renal outcomes that have led a lot of people to ask many questions. But we are not here for the evidence, we are here for what is practical. So remember that the HFpEF ratio data is very encouraging. Even without that, I think this patient with a lower EGFR deserved an SGLT2 inhibitor. That the DELIVER trial is coming that evaluate dapagliflozin in HFpEF. But let's move on with our patients. 57-year-old woman with type 2 diabetes for 10 years on insulin. Can you use insulin, SGLT2 inhibitor, reduced dose in insulin? The answer is yes. What does it do? Here is a meta-analysis of 7 studies, right? There is a reduction in A1C by 0.56%. And what is important is that there was a weight loss in these patients because weight gain is very common with insulin. And there was a reduction in a dose of around 9 international units, right? This is another one that looked at the glycemic variability. There's a reduction in insulin, but not necessarily a reduction in glycemic variability in this particular study. The other important thing to remember, and I just want to emphasize to you, that in patients who are thin, on whom you're considering adding an SGLT2 inhibitor to insulin, be very careful, especially when they have to stop the insulin, the risk of euglycemic ketoacidosis. Lastly, this question is added simply because there's so much pharma interest in dapagliflozin. Here's a patient who's on a dapagliflozin MF. Current visit, he asks, he has heard about lower dapagliflozin and asks if he can switch. Remember that after a certain amount of time, there's a difference between biosimilars and generics. That the law allows you to make generics. The important part is the PK, is the bioavailability and the bioequivalence. And if the bioequivalence is fulfilled, and it can be seen on this particular study, and you really don't need other studies for the law for the regulators to tell you that that the A1C is equivalent, the fasting glucose is equivalent, the creatinine is equivalent, the mycotic infections are equivalent. But I think many companies have established that. And as long as you've looked at the data and you can see that they are interchangeable in terms of bioequivalence and that their potency is the same as the innovator, I think all the innovators have a good amount of time for ROI and continued care. We will need competition to make sure that these are affordable, that there cannot be a group of patients in the country where where they cannot reach drugs. This has to be either by regulation or by distribution or by encouraging competition. And either of these 3 mechanisms will allow patients to get drugs. So let me summarize. What I've done is I've sort of cut through many of the data and lots and lots of data actually make us the same. I hope I've tried to give you situations in which SGLT2 inhibitors are indispensable, are useful, can be used in combinations. And hopefully I've also answered some of the common questions that we have. Can we treat through an infection? Can I combine it with the DPP4 inhibitor? Should I give it in somebody with a lower EGFR? What happens when I give it to a lower EGFR? Can I give it in heart failure? Can I give it after an MI? Can I give it after HFpEF? So I hope this was simple enough for most of you, and I'm happy to take any question. I also think I finished well within time. Thank you, Sanjay and Neeta, for constantly having me in this program. It's an important part of my calendar, and I consider it a pleasure to be part of it. Thank you again for letting me moderate Dr. Tuttle and Sundar's talk yesterday. That was also a wonderful way for us to understand many things. Thank you both.
Thank you very much, Krishna. It's always a great pleasure to have you on our show. I think yesterday's the entire interaction and today's lecture have been absolutely fantastic, very informative, lots of take-home messages. I don't see any questions that I have for you because your lecture has been so self-explanatory. So I'm going to really let you off the hook for today. Thank you so much.
Thanks,
for
Sanjay.
being part
Bye-bye.
of this meeting. Thanks, Atan. Next speaker for the evening is Dr. Sunil M. Jain. Can I have his CV, please? But I can just say extempore about Dr. Jain, that he's such a wonderful person and he has the Total Hormone Institute at Indore. He's doing incredible work at his institute. So here we have it. So he's done his DM endocrinology from Pijmer in Chandigarh in 1995. He's a consultant endocrinologist, and his institute is something that it's an envy for everybody, and everybody should visit it once to see what an ideal clinic should look like. So I have had the pleasure to go to his clinic and see it. And he's key faculty for CME at various meetings. He's been part of a lot of international trials, some of them being leaders, Savotimi, Canvas, Emparec, Verify, Carolina, and he has contributed immensely to literature in diabetes. He's also authored a book, How to Get Most Out of Your Pump. So today we have the pleasure to hear him about modern sulfonylureas, trusted companion of past, present, and future. The stage is yours, Sunil. Thank you.
Thank you, Dr. Sanjay, for the kind words. And let me share my slides. That is modern sulfonylurea, the past, present, and future. And I'm talking this just after SGLT2 inhibitor talk and lot of things because being discussed about what should be done with sulfonylurea now. So let me give you a quick review of the sulfonylurea's past and my expectation about their future. This is what is the sulfonylurea compound being. So they have in common this sulfonylurea structure. And then both sides, this aryl and R2 group keeps changing, and that's how we have different types of sulfonylurea. And why this is pertinent to know, because we are going to differentiate between conventional sulfonylurea and modern sulfonylurea. So whether it is conventional or modern, this sulfonyl component remains as a common in both, and the difference is on the both sides of the groups, which make them different. If we go back to the past, in fact, these are the age-old drugs being used even before metformin for the treatment of diabetes. And we know the 1942s and those eras when some animal trials of the sulfonamide class of drug with name 2254RP was found to have some hypoglycemia. And similarly, cases of typhoid fever in France in Montpellier, when they were treated with this sulfonamide, these people had hypoglycemia. So they tried to find out what's responsible for that, and that's how somehow accidentally sulfonylurea class was discovered. So this is the brief past history. And then like we saw with insulin, what was in 1921 and what are the options today. Similarly, in sulfonylurea, we started with the basic compound like tolbutamide, chlorpropamide, and now we have reached to the modern sulfonylurea like glimepiride and gliclazide. And these are the three major concerns which has been always talked about sulfonylurea. And this I am talking of the era when we were predominantly using conventional sulfonylurea. The major issue was the hypoglycemia and weight gain. The CV safety component was added later, because say around 15-20 years ago, when we were not talking of this cardiovascular safety data. The CV safety issue became important after 2007-8 due to post-rosiglitazone story. Otherwise, nobody was talking about the cardiovascular benefit of the drugs, and that's how we are now into a different world. So if we look at the weight gain and hypoglycemia concerns, they were more often seen with our older generations of sulfonylurea. So let me just touch upon the generations of sulfonylurea. These are this is just by convention now, that's how we are defining it. First generation, few will talk first, second, third generation, or many will tell it just first and second generation. So first generation sulfonylurea, those who are very senior in diabetes practice, they have the experience of using these drugs like chlorpropamide and tolbutamide. When I was doing my MBBS MD, those days chlorpropamide was still available, but remaining were disappeared. So they have now history. All the second generation sulfonylurea, that is glipizide, glibenclamide, and gliclazide, and then third generation glimepiride are available to us. But if we go from their effect point of view, I think the better way of classifying sulfonylurea can be the older generation sulfonylurea and modern sulfonylurea. And in the older generation sulfonylurea, we have still glibenclamide and glipizide we are using. And we know that glibenclamide is a drug which is quite potent in terms of insulin secretion, and hence it causes more number of hypoglycemias and obviously weight gain, because these two adverse effects are interlinked. And then we have now the modern sulfonylurea like gliclazide and glimepiride. So when we talk about modern sulfonylurea like gliclazide and glimepiride, the risk of hypoglycemia and weight gain is far less as compared to the older generation of sulfonylurea. So these sulfonylureas, which are now newer generation, they are working on beta cells in a little different way. Their binding affinity, their tissue penetration at beta cell level is such that they are not unnecessarily stimulating insulin at those quantities which glibenclamide-like drugs used to do. So that's how already one big change has happened when it comes to sulfonylurea. Many things still talked about sulfonylurea may not belong to modern sulfonylurea. They may be true for drugs like glibenclamide, but it is not true for the modern sulfonylurea like glimepiride and like gliclazide. Now, modern sulfonylurea, now let me focus on the modern sulfonylurea. Take an example, glimepiride. What is the effect on weight gain? And now we used to talk in past about a lot of weight gain with sulfonylurea and a lot of hypoglycemia with sulfonylurea. But now we have recently quite big randomized double-blinded trial, which are definitely to a great extent in favor of modern sulfonylurea like glimepiride. So let us quickly review on the effect on weight gain. What is the risk of hypoglycemia if we compare modern sulfonylurea versus the older generation sulfonylurea? And whenever we talk of cardiovascular safety, the connection of sulfonylurea is not with heart failure like the pioglitazone was. The connection of sulfonylurea is with the issue what we call as ischemic preconditioning. So what happens to the ischemic preconditioning with modern sulfonylurea and how it differs from the older generation sulfonylurea like glibenclamide? So these sulfonylureas which are modern, they have a quicker attachment and an earlier detachment. Their tissue penetration is such at beta cell they are causing stimulation of insulin secretion, but they are not continuously stimulating the receptors. So more of a closer to a physiological stimulation. That's how they differ at the receptor level. And we can compare the hypoglycemia of glibenclamide versus glipizide versus gliclazide versus glimepiride, the all four sulfonylureas we have. And we can clearly see here that the older generation sulfonylurea like glibenclamide has quite high incidence of hypoglycemia as compared to glimepiride or gliclazide or glipizide. So the risk of hypoglycemia, when we talk about, we cannot compare glimepiride same as glibenclamide. There is a huge difference because of the pharmacokinetics and receptor binding potential of glibenclamide and glimepiride is entirely different. When it comes to ischemic preconditioning, now here this is an interesting study which is comparing the effect of glibenclamide versus glimepiride and placebo on ST segment shifts during balloon inflammation in percutaneous transluminal coronary angioplasty. And this has been an article which has been published, say, around 20 years ago. And here you can see that the major effect was of glibenclamide. Glimepiride was as good as placebo. But these are the short studies, and similar kind of many studies which we have, which had shown earlier that glimepiride is not interfering into ischemic preconditioning and not causing any bad cardiovascular outcome. And thus we have so many kind of studies here. I am not going to discuss these studies one by one. It will be too boring for all of us. So these all studies in general have given a favorable evidence, because since these modern sulfonylureas are available, so look at all these data. And the story started from UGDP study in 1970s when the tolbutamide is a sulfonylurea, when it was compared with insulin therapy. In those days of 1970s, when this study was done, obviously it was not planned the way current cardiovascular outcome studies are planned. But in these studies, it was shown that there was increased or a bad cardiovascular outcome in the tolbutamide group. And since then, because of this particular study, to all the sulfonylurea molecule, referring to this study, US FDA has always kept a warning of cardiovascular safety on sulfonylurea. Those days, these modern sulfonylurea were not available. Even in the UK PDS trial, only glibenclamide was used. So whatever data we had were with the older generation sulfonylurea to these big, well-known famous trials. And then we had the modern sulfonylurea trials, in which I would like to label particularly advanced trial, where gliclazide in a sustained release formulation was used. Tosca IT trial, where glimepiride was compared with pioglitazone, and the trial which I am going to discuss in more detail, that is Carolina trial. In all these trials, which are of a big number, done in a proper way, we could not find any big or any kind of bad cardiovascular outcome with sulfonylurea. We all understand that sulfonylurea are very useful drugs. We understand that like insulin is also a very useful drug, but can cause hypoglycemia. Similarly, if judiciously used in a right manner, sulfonylurea can be a good choice. But there had been always a concern for sulfonylurea because they work on potassium channels. They work on potassium channels of beta cells, close them, and thus cause insulin secretion. And there had been always a concern because these potassium channels during ischemia, which are lying in the cardiovascular tissue, must open, and that's how ischemic preconditioning will happen. So if sulfonylureas are closing the potassium channel as beta cell as well as a heart, then how they can be cardiovascular safe? So that has been always a matter of debate, which was solved only after this Carolina trial, which I'll discuss after a few slides. So that's how this UGDP trial with tolbutamide had raised a concern, and looking to sulfonylurea mechanism of action of potassium channel blocking effect on beta cell, this concern was genuine, and that's how there was a warning on sulfonylurea because of the mode of action. And in mode of action, it is possible that sulfonylurea may not be safe for the cardiovascular tissue. But during a long period, we did not have any big data or in a double-blind randomized manner. So let us come now to the point of sulfonylurea cardiovascular safety, now we are specifically talking to the modern sulfonylurea. That means when we compare glimepiride or gliclazide, what is the information with us? Let me again do a recap of ischemic preconditioning, and the importance of ischemic preconditioning is to reduce the necrotic tissue area, because during ischemia in cardiovascular tissue, potassium channel will open, and opening of this potassium channel causes vasodilatation. And in addition, it also reduces the cardiac workload, and these together will lead to a reduction in the necrotic area. That's how is the ischemic preconditioning will have a good effect. And for that matter, in cardiomyocytes, there are mitochondrial potassium channels, which are the most likely effector of this ischemic preconditioning. This is known so far. And that's what you can see in this image. If there is no ischemic preconditioning, the necrotic tissue area will be big. If there is a ischemic preconditioning, the necrotic tissue area will be small. And it has been a hypothesis that being a potassium channel blocker, sulfonylurea will go into cardiomyocytes, and there they may abolish ischemic preconditioning, and that's how they can result in a large infarction area, and that finally will translate into a bad cardiovascular outcome. But is it true? It looks hypothesis, but is this hypothesis true? Does the sulfonylurea, and when I'm talking of modern sulfonylurea, does these modern sulfonylurea interfere in ischemic preconditioning? So here we will have to differentiate between modern sulfonylurea and conventional sulfonylurea and their effects. These are the data which are basically retrospective data collected from those patients who are receiving sulfonylurea, and these are huge numbers. Thousands of the patients, their data are collected, and they're just trying to see what is the relative risk. So you can see here that glimepiride and gliclazide was having a lower relative risk of cardiovascular events. So overall cardiovascular mortality wise, in various different trial data, we can see here again, this is a huge number of different trials. And then this meta-analysis also did not show any big increase in all-cause mortality or CV mortality or myocardial infarction or stroke. This is glimepiride, which is associated with reduced mortality rate in diabetes with coronary artery disease, where again glimepiride, glipizide, and glyburide, these three sulfonylurea were compared. These are again retrospective data where those patients who are receiving different sulfonylurea, they are now followed up, and what is the cardiovascular event number is happening, they were counted upon, and that's how this information is created. This is the well-known TOSCA IT trial where metformin with sulfonylurea, metformin versus glitazone was compared, and here we can see again it's comparable. P-value is not significant. So, but here the issue is we talk both about we are talking now about pioglitazone versus glimepiride. So more important, if we want to settle this issue, we were earlier doing the way I'm talking about with some retrospective data, but now fortunately we have a cardiovascular outcome trial on sulfonylurea. And we have a CVOT now that is on glimepiride. Because these are age-old molecules, who will do a CVOT on them? But fortunately, glimepiride was selected in Carolina trial cardiovascular CVOT study, which was a head-to-head comparison with linagliptin. Generally, in a cardiovascular outcome trial, whatever you see, all cardiovascular outcome trials, one group is drug and other group is placebo. I feel that most likely Boehringer Ingelheim have thought that let us take linagliptin in a cardiovascular trial and comparator to be kept as a placebo. Rather than placebo, let us keep comparator as a glimepiride. And it might have been assumed because of the potassium channel story, that very likely glimepiride group will have more cardiovascular events, and that's how the number will be even higher than you will compare with the placebo. And that's how in this cardiovascular outcome trial, you see on one arm is glimepiride and on one arm is linagliptin. So by chance, now we got a very good data on one of the very useful and very often prescribed drug in India, that is glimepiride. This trial, 43 countries, more than 600 sites. And I am also one of the investigators. My center also participated in the Carolina trial. So we are also one among these 600 sites. And when we started this trial, obviously in any cardiovascular outcome trial, it is the number of events which matter. So we have to wait for those number of events to occur. Initially, this trial was planned for 4 years, but number of events did not happen, and it took 7 years to have those number of events. And that's how this trial lasted for 7 years. And in these trials, we took the patients who either had cardiovascular disease or had more than 2 cardiovascular risk factors. And that's how a large number of patients in these trials were our day-to-day clinical practice. And now we were looking for cardiovascular death. So 6,000 patients, double-blinded way, followed up now, either on glimepiride or linagliptin. And now we are following them with the standard care for the management of dyslipidemia and hypertension. And we are looking for now in these 2 arms, CV death, non-fatal MI, non-fatal stroke, hospitalization for heart failure and unstable angina. And that's how this trial was observed. And at the end of the 7 years, now we were for the data, and we know this terminology MACE, that is the 3-point MACE was the primary outcome, and then other things were thought of. And that's how this trial data were released. And to our surprise, the linagliptin and glimepiride were same when it comes to the primary outcome, that is the MACE. That is cardiovascular death, non-fatal MI, and non-fatal stroke. The behavior of linagliptin and glimepiride was found to be same, which you can see in this table. 356 events happened in linagliptin arm and 362 events happened in glimepiride arm, and you can now see cardiovascular death, non-fatal MI, non-fatal stroke. The difference between the 2 groups is statistically not significant. And if you read the top line, that is MACE, you can see the hazard ratio 0.98 means, and with a confidence interval of 0.84 to 1.14, that is on the both sides of spread is equal. That means they have exactly the same role on cardiovascular outcome, but there was one difference, that is weight gain around 1.5, 1.8 kg was higher in glimepiride arm versus linagliptin arm. And to our surprise, if you look, the glimepiride arm was having a stable weight initial gain, and then rather there was a little loss, but there are no further weight gain. And we clinicians have to decide that around 1.5 kg weight gain over a period of 7 years, what significance you want to give to that. But yes, there was a weight gain, and obviously there will be more hypoglycemia. We understand it is a sulfonylurea. So now suddenly now this is another issue. How CV glimepiride turned out to be sulfonyl cardiovascular safe? So then we came to know that cardiomyocytes have potassium channels, but they are of 2 types. One is a sarcolemmal potassium channel and mitochondrial potassium channel. In earlier tissue culture studies, it was shown that glimepirides bind to the cardiac potassium channels. But which potassium channel? Sarcolemmal. It is not binding to the mitochondrial potassium channel. And we know now that the mitochondrial potassium channel are responsible for ischemic preconditioning. And hence, glimepiride, since it is not binding on mitochondrial potassium channel, it is not interfering in ischemic preconditioning. And that's how you can see in 2021 ADA recommendation, and look at the cardiovascular safety and characteristic of sulfonylurea 2nd generation. That means they are talking about glimepiride because that is the only second generation sulfonylurea is available in US, and this is the ADA table. You can see the effect is neutral. So modern sulfonylurea like glimepiride, they don't interfere in ischemic preconditioning. They can cause hypoglycemia, but it is less in number, and our judicious use is important there. And they may cause little weight gain or no weight gain, much weight gain. That's how it's not sulfonylurea. Now we should talk on modern sulfonylurea, which are definitely patient friendly. And that's how I have shown in this slide. And lastly, these modern sulfonylurea have shown a lot of benefits. In addition, they are cost effective. And one important thing we should see into this slide, that is what is happening. We keep talking that sulfonylurea are disappearing, or what should be the place for sulfonylurea. If we understand the pathophysiology type 2 diabetes well, I presume that future sulfonylurea will remain. You can't manage patients without sulfonylurea with their that long duration of history. And here is the evidence. These are the big world trials. And here we can see that in all these trials, more than 50% patients were on sulfonylurea background therapy. So my conclusions, sulfonylurea are used since decades, and they will remain in use for decades. We understand both sides of them, and we keep using them. But now modern sulfonylurea are more reassuring for us. So I conclude with the words that they have a good past record, used in large number presently, and will remain a choice in future. Thank you very much.
Thank you, Dr. Jain. I think it was a very good overall summary about sulfonylureas. It's always been a point of discussion in various meetings that are sulfonylureas are they going to stay, or they're going to be of the future, or they're going to be of the past, considering the new molecules and the data that we have. And your lecture just told us that we are still going to use sulfonylureas for a long time to come, not only because of the cost factors involved in our treatment. So not only because of the fact that they're more cheap and affordable and people have experience with it, but also we still have a good data that they can be used. And you just showed us all the data that how good they are in use for, in our patients. I don't see any questions for you. So thank you very much for this wonderful lecture. And we hope to have you back again physically next year.
Thank you, Dr. Sanjay and Dr. Neeta. Thank you. Goodbye.
Thank you so much. We are going to move to our next segment of the afternoon. And this is going to be more insulin related segment that we're going to talk about. And we're going to do a little switch over here where Dr. Neeta will probably come first, followed by Dr. Ajay Kumar. So I hope, thank you very much, Dr. Ajay Kumar, for agreeing to this switch. Dr. Neeta Deshpande, of course, needs no real introduction. She's been the heart and soul of this meeting. And this excellent scientific agenda that you see through in the entire course of the meeting that has transpired in the last 2.5 days has all been because of her leadership in the scientific program, along with the rest of the team members. So Neeta, I think with all the due appreciation that you've received from various quarters, I think it's a job very well done, and you can go home and sleep well tonight. So I'm not going to take too much of time, and I'm going to just ask you to give a lecture on Indian reality and insulin initiation, choosing an insulin with efficacy, safety, and convenience. So the stage is yours, Neeta. Thank you.
Thank you so much, Sanjay, for that very kind introduction. And I shall straight away start by sharing my screen. Yes, the topic under discussion today is the Indian reality and insulin initiation, and how can we choose an insulin that is efficacious, safe, and convenient all at the same time. I have been supported commercially for this particular talk, and the agenda of my talk would be, should we be worried about diabetes, the burden of diabetes in current times? And in India especially, how is it different? How is the burden different, and how is the management going to differ? And if it is different and there are more challenges, how can we find solutions for that? Is there some solution that we have in sight which will take care of all the problems that India uniquely possesses. So let me go to the first aspect of my agenda, and that is the burden of diabetes, and should we be really worried about it during the current times. You see before you the staggering figures. That is, India is home to the second largest number of adults living with diabetes worldwide, which is actually 77 million people, where 1 in 18 adults have diabetes, and we have more than 57% who are undiagnosed. That translates roughly into 44 million people. And look at the number of people dying, more than 2,500 people dying every day because of diabetes related causes. And all of this in the background of the fact that diabetes occurs earlier in our population, there is higher insulin resistance, and we all have greater insulin secretory defect if you had to compare ourselves to the Western counterparts. And this translates into a very heavy expenditure that is around 52,000 crores of an annual diabetes related expenditure, as you can see here. And the burden of diabetes in India is made worse, not just by the numbers of people who have diabetes, but the number of people who are uncontrolled. You can see here that 4 in 5 people with diabetes are uncontrolled, and you have different studies here in front of you. So HbA1c, which is the marker, which is what we use for assessing the glycemic control, you can see here that the people with type 2 diabetes in India having an optimum A1C of less than 7% is dismally low. And you can see here that the average A1Cs are around 8.4, the fasting around 176, and the PPG around 251, which means that we only have 22% of people with diabetes who have an A1C that is less than 7%. And this is really concerning. And if you look at it from the COVID point of view in this present scenario, the pre-infection glycemic control and disease severity among patients with type 2 diabetes and COVID-19, several studies have shown that there's a very bad relationship between what the glycemic control is and what the COVID severity is going to look like. And you can see here that the risk of severe COVID-19 with people requiring various kinds of intervention was higher in people with a high pre-infection HbA1c. And this means to us that in these times, it is especially more pertinent to keep A1Cs under control, because you do not know if a person is going to get afflicted with the COVID-19. So the relative risk of developing severe COVID-19 with A1C targets at the baseline, and you can see here that it just gets worse as the A1C goes on increasing. So when you actually reduce the A1C by 1%, the risk of developing severe COVID-19 is reduced by a very impressive 21%. So that means it's very important to keep the A1C under control, so that if COVID should strike, it should at least not be severe and not push the patient into an ICU. And therefore, what it means is that if you need to initiate insulin, do not delay it. You find uncontrolled diabetes, make sure that you actually initiate insulin and bring the A1Cs down so that the person is kept safe. And as you all know, this everybody knows, and from time immemorial, that insulin offers the maximum glycemic efficacy. You have different kinds of insulins, no doubt, but in general, they have the best glycemic efficacy compared to any other anti-diabetic regimen that you can think of, whether it is oral or other non-insulin injectables. And therefore, insulin initiation should not be delayed if a person is uncontrolled on oral anti-diabetic agents. Now coming to the next aspect of my agenda as to how diabetes is different in Indians and what challenges does it throw up in terms of management. We all know that we are a high carb country, and therefore we have high PPG levels, and patients are uncontrolled on multiple oral drugs, and therefore we need something that is simple, that is convenient, and there can be all these factors which I've just mentioned. They impact the choice of therapy for insulin initiation, because you have to, especially these first 2 points are something that you have to take care of, high carb and high PPG levels. So your choice of insulin is largely directed or guided by this particular aspect of the Indian reality. As I said earlier, we are a high carb country, and across the country, 61 to 70% of energy intake is through carbohydrates present in the diet. And these are different areas in the country, and north to south, east to west, we are definitely a carb rich country, and this is the reality. So this is the Asian picture about contribution of A1C by fasting or by postprandial glucose at different levels of HbA1c. All of us know the studies by Monnier, and we know that he showed us that the higher contribution of PPG at lower A1C levels and that of fasting at higher A1C levels, and this was Caucasian data. But this is true in Indians, but the other end of the spectrum is not true, which means to say that even at high levels of A1C, PPG contributes significantly to the HbA1c, unlike the Caucasian data that was there in 1 year. So what it means in general is that postprandial hyperglycemia contributes to A1C across the spectrum of all levels of HbA1c, and hence is an important consideration when you are going to choose insulin therapy. So if you had to choose insulin therapy, and according to most guidelines, we start with a basal insulin, can a once daily basal insulin really cut the ice? Does that really help us to do it? And the question to be answered is, can a once daily basal insulin be suitable in case of a high carb diet? Obviously not, because it doesn't really work much on the postprandial hyperglycemia and does not offer direct control of postprandial hyperglycemia. And can it really be suitable in case of delayed insulin therapy, which is often the case in India? Insulin is delayed for very long. There is data to show how long it is delayed, and there's so much of clinical inertia, patient inertia, physician inertia. So in that case, does a basal insulin help? And does it offer the convenience at initiation itself of both fasting and postprandial control, which is what is required in the Indian scenario, as I have already shown to you. And therefore, a prandial component cannot be neglected in Asians, even at the very start of therapy when insulin is started, which is started anyway way too late in Indians. And therefore, we have a solution for that. And this I would call a total solution, a two-in-one solution, meaning both fasting and postprandial right from the beginning. So the molecule under consideration that I'm talking about today is Idec ASP, once daily, which provides total control and suits the Indian reality of diabetes management, because in a single formulation, you have an insulin aspart, which takes care of the largest meal of the day, and you have a flat and stable control for more than 24 hours with insulin degludec. So you have a prandial component taking care of the largest postprandial spike of the day, and a basal component that takes care of more than 24 hours of the basal part. So this appears to be like a total solution. It has undergone several phase 3 clinical trial programs, and as you can see here at the bottom, as you can see here at the bottom, it has been pitted against several other norms of treatment, such as versus insulin detamers, versus analog premix, versus glargine U100, and against a multi-dose insulin therapy, and extensively studied against all these comparators. The RSSDI ESI clinical practice guidelines also recommends that a once daily Idec ASP is recommended as a choice for insulin initiation, although they have mentioned that insulin therapy should be considered when patients fail to achieve glycemic targets on 3 oral agents, which is actually the Indian reality. Most people would go on 3 oral agents before initiating insulin, and then this should be the first drug of choice. Obviously, the psychological aspect of it is that you should never use insulin as a threat, and you should alleviate patient anxiety about insulins, and it should be brought into the conversation very early on and not used as a penalty or punishment. So which insulin to choose when patients are uncontrolled on oral drugs? And this is a study that was done in insulin naive patients with type 2 diabetes, and they were randomized to receive either Idec ASP once daily with the oral drugs, or glargine U100, which is just only a basal insulin with the oral drugs. And what you find here is that you have a superior A1C reduction, 1.4% actually, and at the same time, a similar fasting plasma glucose control with 70% of basal component. So it means to say that you have received your you have achieved your A1C goal, and you also have achieved the fasting plasma glucose. So that is an important aspect of it. And importantly, the results also showed that the control of postprandial hyperglycemia was very significant, 57 milligrams more, with a lower risk of hypo. So this is actually a dream, that you can get a better A1C, a better fasting glucose, an adequate postprandial response, and a low risk of hypo. So it's all rolled into one. So in patients uncontrolled on oral drugs, insulin initiation must offer better efficacy without compromising on safety. And as I said earlier, you could achieve an A1C of less than 7% in this study that was pitted against insulin glargine without hypoglycemia. So what it meant was that with IDEC-ASP, 72% more patients achieved their targets without experiencing hypoglycemia as compared to the standard of care that was there, that is glargine. So there is real world evidence also to tell you the same things. Insulin initiation in OAD failure of patients with type 2 diabetes, can it be a new script for the subcontinent? And this was presented as an abstract. So insulin initiation in OAD failure, as I said, this abstract showed us that IDEC-ASP caused statistically significant greater reduction in A1C as compared to euglargine and glargine U300 as well. So this was the important aspect of this particular poster, that you got very good A1C reduction as compared to both the strengths of glargine used alone in patients who had failed their oral drugs. So the change in fasting and PP also was very significant for us to see. And you had significantly better fasting reduction with IDEC-ASP and glargine U100 compared to the 300, and significantly better PPG reduction, which was very obvious because there was aspart in this co-formulation compared to iGlar U100 or U300. So you had all the parameters covered, as you can see from this study as well, that of A1C, that of fasting, and that of postprandial blood glucose. Again, there was a significant increase in insulin dose requirement in the glargine U100 arm, and a non-significant increase with glargine U300 and IDEC-ASP arms. So you are doing this with lesser insulin if you have used IDEC-ASP, apart from the benefits that you got in terms of A1C, hypoglycemia, fasting, and PP. And also, there was no significant difference in this particular paper in hypoglycemia occurrence within the groups. Now, this is another important thing to understand over here, a good poster presented at the ADA 81st Scientific Sessions of efficacy and safety of once daily fixed ratio co-formulation of digludec aspart plus EMPA, a combination of EMPA and linagliptin in post-discharge COVID-19 pneumonitis type 2 diabetes patients treated with dexamethasone during inpatient stay. So all of us know that people with severe COVID or people who received steroids had uncontrolled fluctuating sugars, and that is why this study becomes very, very important. So this was a study with, as I said, persons with diabetes, COVID-19, steroids, recovered, discharged, and 14 days post-discharge, they were discharged on basal and bolus, but they failed to achieve their targets, 100% of the patient, and therefore they were switched to this combination that I spoke of. And at the end of 13 weeks, what you see is an A1C reduction from 10.6 or so to around 6.8, and FPG reduction to very impressive levels, and a PPG reduction from around 300 to just 154. So the practical recommendation is to give it with the largest meal of the day because it contains aspart, and you initiate with about 10 units. And if the fasting is above target, you add 2 units. If it is at target, you maintain the dose. And if it is below target, you reduce by 2 units. So this serves as a convenient and simpler option for insulin intensification as compared to adding more number of agents. So patients with type 2 diabetes uncontrolled on basal insulin, if you had to divide them, this was done in this particular study where they were given Idec ASP with the oral drugs as compared to insulin glargine with aspart separately, and this was in one arm, that glargine and aspart and oral drugs. And as you can see here, the results showed an A1C reduction of 1.1%, a significantly lesser dose requirement of insulin, 12%, and nocturnal hypos especially was very, very important because there was significantly lower risk of nocturnal hypos. And this is the power of a single solution of a 2-in-1 formulation where both fasting and PP are done. So insulin initiation and intensification with Idec ASP has got all of these attributes, and you can see here that the green shows you significantly better and the gray shows no difference. Whether you and if you compare it with initiating with basal insulin or switch from basal versus basal plus, or a switch from premix versus biasp 30, in every which way Idec ASP gives you a very good profile as when you look at A1C, PPG, as well as nocturnal hypos, confirmed hypos, and in all the parameters it helps us very much. And therefore insulin co-formulation provides total control of PPG and FPG, A1C, fasting, PP, and the high intake of carbohydrates is taken care of. It tackles high carbohydrate diet with major meals, optimum control of fasting and PP, and also the important thing is it allays the fears of hypoglycemia. It is administered with an insulin pen, which gives you accurate dosing with least injection force, and you can enjoy the convenience and simplicity of this, that it is one insulin, one injection, one device, one site, but it's a co-formulation with 2 molecules in the same kind of pen. So thank you very much for a patient hearing. And if there is any question, I would be happy to take that.
Thank you very much, Neeta, for this wonderful presentation. I don't see any questions for you, but I will definitely revisit you once Dr. Ajay Kumar finishes his talk. So thank you very much for having you on this. And I'd like to move on to our next lecture by Dr. Ajay Kumar. He will be talking to us on changing paradigm in type 2 diabetes care with oral semaglutide. May I have the introduction of Dr. Ajay Kumar? I'm sorry, you've got the wrong introduction. Can you please, you've got the wrong introduction for Dr. Ajay Kumar. I don't know, when did you become a urological surgeon, Ajay? So that was quite a jump from being an endocrinologist to urology.
He is our boss, the politician, Dr. Ajay Kumar.
But anyway, I would just like to introduce Ajay. I think he's one of the most prolific speakers in diabetes. He's based out of Patna, and I think it's always a pleasure to hear Ajay on his take on various aspects about diabetes. He's a master where insulins are concerned, and every time that I hear his talk on insulins and GLP-1 analogs, I always take back something in learning from his talks. So with this small introduction, I would like to ask Ajay to give his talk. The stage is yours. Please give your talk on semaglutide. Thank you very much.
Thank you, Sanjay. And I would like to thank right at the outset Novo Nordisk, Dr. Sanjay Agrawal, Dr. Neeta Deshpande, and the entire team of Idec for giving me this opportunity to share some of my feelings about this new molecule. And I think when we talk about management of type 2 diabetes and the scientific evolution therein, I think we have a relentless march of scientific events which have unfolded and given us wonderful molecules to treat type 2 diabetes. And this is something which is very beneficial, not only to the practicing physician, but also to our patients. So I have a very brief agenda. I shall be talking briefly about the role of GLP-1 receptor agonists in the management of type 2 diabetes.
And then we shall be looking at some very exciting data coming out of the pioneer set of studies, triumphing targets with oral semaglutide, which is the first GLP-1 receptor agonist in the oral form. And then we would like to translate the message that we get out of these clinical trials to use this molecule in clinical practice. So let's just start with this. I think whenever you embark upon looking at an ideal oral anti-diabetic drug, the first thing that you would like to have is a good efficacy in terms of controlling the HbA1c, but at the same time, you would like that the molecule in question should not lead to hypoglycemia, weight gain, and other off-target effects. And certainly when we like to put our patient at close to 7% of HbA1c target, we are looking at no risk or low risk of hypoglycemia, no weight gain, minimal off-target effects. And now in modern context, because we are now living almost more than a decade in what we call the cardiovascular outcome trial era. And it is imperative that any new molecule should meet the criteria of cardiovascular safety and, if possible, cardiovascular benefit when you use a particular drug to treat type 2 diabetes. And that brings us back to the famous ominous octet propounded by Ralph DeFronzo in his famous Banting lecture, if I recollect correctly, in 2009. And out of those 8 pathogenetic mechanisms, a GLP-1 receptor-based molecule would actually target 6 of them. And certainly, the primary effect is on the beta cells of the pancreas, where they lead to insulin secretion in a glucose-dependent manner. And at the same time, they also lead to glucagon suppression in a glucose-dependent manner. And it was very interesting that at least in the animal model, and subsequently based upon some clinical data, they also increased insulin biosynthesis. And then their action on the gut and their action on the brain, these were the 2 effects which led to a remarkable decrease in the body weight, which is so very important in treatment of type 2 diabetes, because if you can improve the satiety, that will lead to reduction in the food intake and obviously a reduction in the body weight. Because of the presence of cardiomyocytes on the heart and on the blood vessels, they have a direct effect in affecting the cardiovascular outcome, and through different mechanisms like decreasing the hepatic glucose production, improving hepatic insulin sensitivity, and reducing de novo lipogenesis, they will lead to a reduction in the hepatic fat. And similarly, they would also improve the sensitivity within the muscles. All these pathogenic mechanisms are favorably affected by the use of a GLP-1 receptor-based molecule. Now, this brings us to the clinical scenario where majority of our patients are actually treated with 1 or 2 oral anti-diabetic drugs. And then the patient is not at the target of the HbA1c. And as a clinician, you have multiple choices. You can go on to add another oral anti-diabetic drug or an insulin or a GLP-1 receptor agonist. But the clinical question in the minds of the physician is that by adding any of them, what are we going to achieve? Are we going to achieve a significant HbA1c to the target? And if you do that and compare with all other modalities, GLP-1 receptor agonist, as you can see here, give you the best outcome. Similarly, if you want another additional outcome, that you want to actually achieve the HbA1c, and at the same time, you would like to have either no weight gain or in fact a weight loss, once again, GLP-1 receptor agonists do much better. You would also like to keep the number of oral drugs as minimum as possible, because we know that higher the pill burden, lesser is the compliance in the treatment. And therefore, if you add GLP-1 receptor agonist, you can see here that you can keep the pill burden to as low as possible. And similarly, you have a number of other issues like HbA1c to the target, no weight gain, etc. And in all these conditions, you can see that GLP-1 receptor agonist stands out much better than adding an oral anti-diabetic drug or adding an insulin. So this is extremely important that when we look at the composite clinical outcomes, adding an GLP-1 receptor agonist is always better than the other treatment options. But here is the problem. GLP-1 receptor agonists hitherto are available only in the injectable form, and through any survey, your personal experience and the clinical data, you know that physicians and patients across the world would not like to take injectable options and would prefer much more a tablet. And this is clearly what we call the patient preference. Patients will be given, let's say, an injectable through a vial and syringe. They will accept it if it is life-saving. But if the same thing is given through a tailored, engineered pen injectors, which we have seen over the last 2-3 decades now, the compliance and adherence is much better. But certainly, there is absolutely no comparison when they take an oral tablet. Certainly, it is going to improve the compliance and adherence of a particular treatment regimen. That brings us to the pioneer set of trials, and I'll start some very interesting strategy that is important to understand before I give you the data. Whenever you actually use an oral tablet rather than an injectable option, it actually addresses a lot of barriers associated with the injectable treatment. And obviously, that will also give the clinician an opportunity to start that particular treatment option much early in the natural history of the disease. And obviously, that will give better patient outcomes. That will certainly improve the compliance and expand the treatment options. So all these benefits of an oral treatment is extremely important. But unfortunately, to create a large protein into a pill, we have to overcome many challenges. The first challenge is that when the tablet enters into the stomach, it actually meets with a milieu of a very low pH and presence of abundant amount of proteolytic enzymes. So we have to prevent this enzymatic degradation. At the same time, when you look at the gastric epithelium, there is limited permeability across the gastrointestinal epithelium. And we have to improve this permeation through the gastric epithelium to have a better bioavailability, which we know is extremely poor when you give a large protein in a tablet form. And to do that, you have to do a number of innovations. And actually what you have to do is to improve the absorption across the epithelial membrane and do many more things to make an oral protein which is clinically effective, safe, and very helpful to the patient. And that brings us to this wonderful innovation, what we call semaglutide, which is the foundation stone for a peptide in a pill. Now, this is a GLP-1 receptor molecule, and we have done some very interesting molecular engineering. The first thing is that at position 8, there is an amino acid substitution. You can see that the alanine has been replaced by alpha amino isobutyric acid. How does it help? It prevents the DPP-4 degradation, which is extremely important to prolong the half-life of a GLP-1 receptor molecule. And then to further improve the half-life, at position 26, where we have the lysine, you attach a glutamic acid spacer and you attach a very heavy C18 fatty diacid chain. And that leads to very strong binding to the albumin and prolongs the half-life. But there is a problem. Lysine is also present, not only at 26, but at position 34. And there will be wrong site binding. And therefore, it is important that at this point, we do another amino acid substitution. Lysine is replaced by arginine. When you do these engineering, what you achieve is a 94% homology to human GLP-1 and a T-half, which is 1 week. So we are talking about a GLP-1 receptor agonist molecule, which has a half-life of 1 week. That is absolutely astounding and going to make a paradigm change in the treatment of type 2 diabetes. Now, when you look at this semaglutide molecule, which I just discussed as to how it was developed, you can clearly come to a conclusion that this is the most effective GLP-1 receptor agonist tested till date, and it has a very long half-life of 1 week. But as I told you, there are a number of barriers which have to be overcome to improve the absorption across the gastric epithelium and to improve the bioavailability. And to that end, semaglutide has to be combined with SNAC, which is an absorption enhancer, which promotes the semaglutide absorption across the gastric epithelium. And at the same time, it enhances the bioavailability of the semaglutide. So the scientist's challenge is to bring these two molecules together, have their pharmacological actions suitable for human consumption and for clinically meaningful outcomes. And this indeed is the oral semaglutide tablet, which is now available for clinical use. It is already approved by FDA, I think a couple of years ago in 2019. But we have to understand about this low bioavailability. And if you give this molecule at a weekly interval, because we know that the half-life is 1 week, then there is a lot of variability in their concentration. So how do we overcome these limitations? The first thing is that even if the half-life is 1 week, we give it on a daily basis. So once daily dosing will lead to several treatment doses, and the entire variability of the concentration will disappear. And at the same time, the patient compliance with these dosing conditions is not going to be affected, because once daily is very nicely accepted by majority of the patients or majority of the drugs in clinical practice. So now when we understand the science behind this new molecule, I think we have to put into perspective the clinical trial data which has led to the approval of this molecule. And these are the pioneer set of clinical trials, clinical pharmacology trial, phase 2 trial, and a very humongous data which has come from phase 3A trials. You can see large number of patients, more than 9,000, of course, placebo were there, and almost more than 5,700 patients in the semaglutide arm. Now you have to answer clinical questions. If a patient is not on any therapy, the patient is only on diet and exercise, then you have to compare semaglutide with placebo. If the patient is already taking oral anti-diabetic drugs, I think you have to demonstrate its efficacy vis-a-vis SGLT2 inhibitor, vis-a-vis DPP4 inhibitor, or in fact, injectable GLP-1 receptor agonist. And there are other clinical situations where you would like to give flexible doses, because we know that semaglutide is available in 3, 7, and 14 milligram doses. Then in clinical practice, you have large number of patients who are already taking insulin, and whether addition of semaglutide is going to give them further benefit. This is extremely important, because we know that majority of these patients who are on insulin have spent significant length of time post-diagnosis, sometimes 8, 10, 15 years. And whether so late in the natural history, this kind of molecule is going to be effective or not is extremely important. And then we have other studies, the cardiovascular safety studies done in Japanese subjects exclusively, and then the long-term cardiovascular outcome trials. So I'm giving you a snapshot of what exactly happened in these trials. And now first look at the efficacy data. So change in HbA1c in majority of these trials, 1 to 5, 7 to 8. Pioneer 1 was monotherapy compared with placebo. Pioneer 2 against empagliflozin, 3 against sitagliptin, 4 against liraglutide, 5 in patients with renal compromise, and 6, of course, the cardiovascular safety trial and other trials. Now, what we clearly see here across the board, as you can see here, that we have close to 1.5% of HbA1c reduction with semaglutide 14 milligram. And in fact, 7 milligram doses also gives you close to 1 to 1.2% reduction in the HbA1c. And in every case, it is better than the comparator, whether it is an SGLT2 inhibitor or a DPP4 inhibitor, or even an injectable GLP-1, in this case, liraglutide. And it is also important that what proportion of your patients are reaching the HbA1c target of less than 7%. And it is not surprising that those patients who are taking 7 or 14 milligrams of semaglutide, they have done extremely better as compared with any of the comparators in these set of clinical trials. Now, when you talk about what proportion of patients, close to 70% of these patients actually reach the target of an A1C of less than 7%, which translates into 7 out of 10 patients. And I think this is something which is extremely robust outcome so far as the efficacy of semaglutide is concerned. Now, we all know that higher the baseline HbA1c, greater is the HbA1c reduction, not only with semaglutide, but with any other molecule in clinical practice. But it is very interesting that this number of trials that I was talking about, you can see here that if only the baseline HbA1c is more than 9%, you can see a close to 2 to 2.5% reduction in the HbA1c in almost all these studies. This is something which is extremely helpful to make a conclusion or to make a decision as to how to place this molecule in clinical practice. And you would agree with me that majority of our patients on 2 or 3 oral anti-diabetic drugs, when they come for further enhancement of treatment, I think majority have an A1C which is more than 9%. So in such situations, by adding a semaglutide, you can expect a reduction of the HbA1c more than 2%. And this is humongous. Now, when you actually look at the time spent in glycemic control, which is now becoming very important objective parameter about the success of any molecule to treat diabetes, you can see that as compared with any other molecule, oral semaglutide is doing much better over a period of time. At the end of 13 weeks also, you can see that it is doing much better than the comparator empagliflozin. So 40% greater time is spent in glycemic control as compared against empagliflozin. The second important clinical outcome is the reduction in the body weight. And as you can see again, across these trials, what we are seeing is close to 4 to 5 kilograms of weight loss with 14 milligrams of semaglutide. This is something which is very consistent. And as you can see here, this weight loss is even better than the injectable liraglutide. You can see here, clear statistically significant difference between semaglutide 14 milligram and liraglutide full dose. And this is extremely important. Now, when you talk about the body weight reduction, can you actually lose equal to or more than 5% of your body weight? And if you look at the data from the pioneer set of trials, significant proportion, and when I say significant proportion, you can see here, more number of patients lose actually 5% or more of their body weight when you are using 14 milligrams of semaglutide as compared with any of the comparators in the entire set of these studies. Now, if you combine these two clinical outcomes, then obviously the same result will come, that the 14 milligram dose of semaglutide will give you a better composite outcome of HbA1c reduction and equal to or more than 5% weight reduction in those individuals. So this is a very important clinical outcome that we are talking about. So when you are actually looking at the odds of achieving these composite outcomes, you can see these mathematical figures that as compared with empagliflozin, sitagliptin, liraglutide, or whatever in any clinical scenario, renal compromise or whatever, you have a very impressive reduction in this composite outcome of HbA1c reduction and a weight reduction of equal to or more than 5 kilograms. So this is extremely good message that is coming out from the pioneer set of studies. Now, any new anti-diabetic drug has to meet the criteria of cardiovascular safety. And not surprisingly, Pioneer 6 study was done in a population of age 50 years or more with established cardiovascular disease or more than 60 years with at least one CV risk factor. And then this was a very interesting study. This study was not powered to demonstrate the superiority, but this was powered only to give you the cardiovascular safety. Close to 99.7% completed the study, vital status known in 100% of the patient. AE profile was not significantly different from placebo. And the important thing was, not surprisingly, HbA1c and body weight reduction was there. And what we see here is a 21% reduction in the primary MACE component, you know, the cardiovascular death, the non-fatal MI, and the non-fatal stroke. But if you look at this confidence interval, it has gone beyond unity, and therefore it only meets the criteria of non-inferiority by a very robust p-value, 0.001, but it does not reach the superiority because it was an event-driven trial. It was not a duration-driven trial. If the same study is prolonged over a long period of time, then maybe that it will demonstrate superiority. And to that end, we have a sole study, which I will just allude to in a bit. In Pioneer 6 study, as you can, not surprisingly, the change in the HbA1c was much better against placebo, and observed change in the body weight also, not surprisingly, is much better with semaglutide. Now, we also know that semaglutide is already available in injectable form. And we have a SUSTAIN 6 cardiovascular outcome trial, a dedicated cardiovascular outcome trial, which had 26% statistically significant reduction in the MACE. And here we have 21% non-significant reduction in the MACE. If you pool these two data with semaglutide, injectable and oral, you clearly see a 24% statistically significant reduction in the MACE component, all the primary endpoint. And this is what I was talking about. SUSTAIN 6 was both event and time driven, but Pioneer 6 is only event driven. It was a very short duration trial and therefore not powered to demonstrate superiority. As you can see here, there were 254 CV events in SUSTAIN trial, whereas only 137 CV events, which actually was sufficient to demonstrate cardiovascular safety. A median observation time here, 2.1 years, where it was only 16 months, and MACE reduction was 0.74 and 0.79. So I think it is very clear that the trend which we see in the Pioneer 6 study actually gives you a lot of hope that if you actually do a dedicated cardiovascular outcome trial with adequate number of patients for adequate duration, possibly it will also demonstrate superiority. So when we summarize the effect of oral semaglutide, it is definitely superior against empagliflozin and sitagliptin in terms of A1C reduction, numerically better than even liraglutide, but not statistically significant. Weight reduction was much better with any of these comparators. And at the end of trials, oral semaglutide demonstrated significant greater HbA1c and weight reduction as compared with any of the comparators. I already alluded to about the cardiovascular safety and the overall safety as compared with placebo or with any other comparators, there wasn't much difference. And the good thing is that it doesn't matter whether you have renal insufficiency, hepatic insufficiency, or elderly population, there wasn't any problem of using semaglutide. Coming last couple of slides, how do you take semaglutide in clinical practice? It is important that you take the semaglutide tablet first thing in the morning. You have not taken any water, you have not taken any fruits, nothing, not even a biscuit. And this is extremely important that you take the tablet with half a glass of water, close to 120 ml. And for next 30 minutes, you are neither going to drink nor going to eat. That will give you the best concentration. And you will start with the lowest dose to avoid the gastrointestinal side effects, continue for 1 month, then increase to 7 milligram, again continue for 1 month, and then finally increase to 14 milligrams. That is the best way to use. And if you have missed a dose, don't take it at other times. Wait for the next day, because you know that the half-life is 1 week, yet you are giving on a daily basis, so nothing to worry about it. Practical approaches to treat nausea, we already know. There are very simple methods by which you can actually improve the outcome in terms of mitigating the effect of nausea, or at best for a temporary period, you can also stop the drug and restart at the lower doses. So ideal patients for a starting semaglutide are those who are taking 1 or 2 oral anti-glycemic agents, inadequate glycemic control. This is the appropriate drug, where weight loss is desirable, where hypoglycemia has to be avoided, where patient is already receiving an injectable GLP-1 receptor agonist and is not reading to the target or is not adherent with the treatment, patients with established cardiovascular disease, patients with renal or hepatic dysfunction, and elderly patients. All these clinical situations will give you excellent clinical outcomes. This is the usual treatment guideline, which now puts into perspective that GLP-1 receptor agonists have to be used as the first agent in patients of type 2 diabetes who are high risk of cardiovascular diseases. In all these situations, semaglutide could be an excellent choice for using in clinical practice. Let me conclude by telling you that GLP-1 receptor agonists are the most effective medications to treat type 2 diabetes, and oral semaglutide is a true scientific breakthrough. And through the Pioneer trials, we have demonstrated the efficacy, safety, and most important, that all the comparators were actually inferior as compared against semaglutide for different clinical outcomes. And therefore, semaglutide has to be considered very, very importantly in clinical practice, because you are talking about a robust reduction in the HbA1c and many other pleiotropic benefits. Thank you very much for your kind attention.
Thank you very much, Dr. Ajay Kumar, for this wonderful presentation, very lucid, and as always, very informative. I said this at the beginning of your talk, that I always have lots to learn from this. I just have a question to ask you. With the introduction of oral semaglutide, where do you see now the injectable semaglutides, injectable GLP-1 analogs are going to go? Do you think there will be a major shift to oral semaglutide from injectable, given the fact that people are always afraid of taking injectable GLP-1s? And 2, do you think it's going to revolutionize now and the whole treatment algorithm is going to change, that we are going to now see more, more in the hierarchy of treatment, oral semaglutide with SGLT2 inhibitors, insulins, and then of course all the rest of the agents? So you think that you foresee this?
First part of the question, that patients who are on injectable GLP-1, I'm sure, given the availability and the opportunity to use it, 100% of the patients will shift from injectable to oral options. Why should anybody take an injection? I think I and you, if given the choice, will take the tablet rather than injection. So I'm sure everybody will take it, because what we have demonstrated is not a comparative efficacy. We have demonstrated superiority in most of the clinical outcomes as compared with injectable GLP-1 receptor agonist. And secondly, moving it up in the hierarchy of the type 2 diabetes management, I'm sure patients without established cardiovascular disease, it will automatically become the second choice after failure of metformin. And patients with cardiovascular diseases, it may even move up to the first place. I know, I'm sure everybody is aware about the constraint of costing. We still don't know what will be the cost of this molecule, because we have the experience of a very high cost GLP-1 injectable receptor agonist. I don't know what will be the cost of oral formulations, but if the patients will be able to afford it, I'm sure this will move much, much higher in the hierarchy of management of type 2 diabetes.
Thank you. I just have one more question to ask you, that although we don't have any indicated use as of now, do you think it may turn out to be an anti-obesity agent in future, given that, okay, the trials will come to us in future and, we will be seeing it. But as of now, do you think people will start using it as an off-label indication?
Yeah, they might do. They might do. We have also seen this happening in the other parts of the world. I remember way back in 2012, the same phenomenon happened in Brazil, where people started, in fact, using off-label liraglutide for these purposes. So it is quite possible, but from the scientific fraternity, we should give clear message that this should not be done. Because there are other very many ways to do that. So and this is quite an expensive option.
Agreed, absolutely. I was just trying to tease your brains to see what your take would be. But do you think now we are moving to a more compliant partnership, where you may have once a week semaglutide with, in future, once a week Icodec coming in from the same company, and it may become more sort of easy to treat patients with diabetes and obese. So you have once a week formulations, and people will be very happy. They'll have better compliance. Of course, cost may be a considerations, but where people can afford it, do you think people will shift to this kind of a combinations in future?
Yeah, and a lot of this will depend upon an individual patient's preferences. I'm sure when we talk about individualization of treatment, we know that there are many patients who say, oh, I'm already taking one injection, so why not take the second injection as well? Why should I confuse myself by taking the first thing, one oral tablet in the morning, and don't take anything for the next 30 minutes? When I'm already taking one injection, let me take 2 injections a day. So I know that individual preferences will actually guide you in those situations, rather than the imposition of a desire by the physician that you should do this and you should do that. When you actually discuss the options with the patient, you will see some surprises.
Thank you very much. I think it's been an excellent session. We have run out of time. Thank you very much for this wonderful presentation. Thank you so much once again. And I would like to thank all the people who have been participating in this hall for their attendance. And I would like to urge you to move to the Neeraj Chopra Hall now for the session, the entire symposium on obesity. So thank you very much. And I'll end this session over here. Thanks a lot.